Okay, so hi everyone. Assalamu alaikum. My name is Momo Arai. I'm a fourth year medical student, and along with me is for today's pharmacology review is Shaimaa, and yeah, go ahead. Okay, yeah. So we're really glad to be giving this review, and we really hope that it helps everyone. And yeah, we can start because we got a lot of questions. So. Okay, so for the first question, which of the following antibiotics is associated with a high incidence of nephrotoxicity? You guys can answer in the chat or unmute, yeah, up to you. Okay, C. Okay, does anyone does anyone know why? Like, if you want to explain the answer? Okay, everyone's saying C so far. Okay, yeah, there you go. The answer is C. Now, if you wait, can you move to the next slide, Shema?
Yes, sure.
Yeah, okay. So the explanation for this answer, I'm really glad you guys got the first answer right, but it's basically recall of how drugs are being metabolized, right? So drugs can be metabolized either by the liver, hepatically, or renally. And now this table is like a summary for that I made last year for a PAL, but it's a summary of how which drugs are eliminated in which way. And the ones in red are like the exceptions of the classes. And now you can see here vancomycin is renally excreted, and that's why it's the only drug in the list that can cause nephrotoxicity or um that can so people who are renally impaired, you should be careful when giving them vancomycin. I hope that's clear to everyone. If it is, we can move on. Okay, good. So second question, a man suffering from extensive burns on the hands and face came to the ER. After admission, the patient started to have fever and looked in distress. The wound dressings of the burns show a green pus, and upon culturing, he was diagnosed to have an infection caused by Pseudomonas aeruginosa. Which of the following medications should most likely be prescribed? Again, it's also kind of recall, but yeah, it's very important to know. Okay, someone said B. Someone said E. What about the rest? Okay, C. Okay, good. I'm seeing like a lot of mixed answers, so that's C. Okay, C. Okay, mostly C. Um, does anyone want, okay, press. Okay, it's fine, but the answer is E. And so basically the class of the cephalosporin drugs, there's 5 generations, right? Ceftriaxone, which is C, is it's a third generation drug. Wait, can you go to the next slide? I have the slide from your pharma lecture. Yeah, here. So ceftriaxone is a third generation cephalosporin, but it's not effective against Pseudomonas. The ones in red here are effective against Pseudomonas, so it's very important, which ones are important for, which ones are effective for Pseudomonas, right? The whole question before, all of the scenario wasn't important. You just had to know that how would you treat Pseudomonas. Again, ceftazidime, the one how I used to remember it was by the dime, right? So it used to treat Pseudomonas, even though it's third generation. And fourth generation drug is cefepime. But the fifth one, do you see it's in red, but it has no activity against Pseudomonas. Can you go back to the slide again? Sorry. Yeah, so here, so the answer is E, cefepime. It's the fourth generation anti-pseudomonal drug. Um, B is fifth generation, but it has no activity against Pseudomonas. So make sure you to remember those two. So the only two from the drug list again was cefepime and ceftazidime. Yeah. Can you go to the next slide? There's one more. Okay, so this one here is a very general way to memorize it if you want to know the 5 classes. The first three, like they're effective against gram-positive mainly, but decreasing effectiveness. From third generation onwards, it's mostly gram-negative and so on. Again, the only gram-negative, wait, something, okay, the only third generation cephalosporin that's that's effective against Pseudomonas is which one again? It was supposed to be on the slide, whatever.
Ceftazidime.
Yeah, good. Ceftazidime. Fourth generation is effective against Pseudomonas. Example, cefepime. I don't know how to pronounce it like the correct way. But from fifth generation onwards, MRSA, but not Pseudomonas. Is that clear for everyone? I hope that makes sense. Okay, good. Yeah, can you go to the third question? Which of the following is the correct mechanism of action of ceftriaxone? We mentioned this drug just now. Okay, B. Does anyone have any other like answer? Okay. Okay, C, B and C. Okay. Do you want to show the answer? Okay, there you go. The answer is B. Ceftriaxone is part of cephalosporins, and their main like penicillins in general, their main action is against the penicillin binding proteins, which cross-links the cell wall peptidoglycans. Right? There's a picture on the next slide also. Wait, can you go to, yeah, here. So for example, this is where is it? Beta-lactam antibiotics, everything, they kind of bind to the PBP, which is the transpeptidase, sometimes called, yeah, also called penicillin binding protein. So when they bind, these enzymes don't work in cross-linking like the cell wall, basically, the peptidoglycans. Is that clear? Now, I think someone said C, which is binds to D-ALA. It mimics D-ALA to be able to bind the enzyme, but what it binds to is the enzyme itself. Okay, is that clear? Oh, okay. Does anyone know? Okay, does anyone know what binds to D-ALA? Like it's not cephalosporins, right? Yeah, good job. So vancomycin binds to D-ALA. Penicillins in general, they mimic D-ALA. Okay, if that makes sense. Okay. Do you have? Okay, if no one has any questions, I'll move on. Okay, I hope that's clear. Okay, good.
Okay, so now
Fourth
this
question.
question.
Oh yeah, it's Shamia's.
A 43-year-old male presented to the clinic with a cough and a low-grade fever. After investigations, he was diagnosed with pneumonia caused by the bacteria Mycoplasma pneumoniae. The antibacterial he was most likely prescribed works by, I'm sorry for the double prescribed, but yeah. What do you guys think the answer is? So basically the question is asking which drug works against Mycoplasma. C. Okay. Any other answers? C again. Okay. So any other answers? When you say C, what drug do you have in mind? When you say C, what drug do you have in mind? And when you say D, what drug do you have in mind? So C, you have macrolide in mind, and D, tetracyclines. Okay. So the answer is actually D, because I'm gonna go over all the mechanisms of actions in a while, but basically the drugs that cover atypical bacteria like Mycoplasma, Chlamydia, they're basically, the mnemonic is FAT, so it's fluoroquinolones for F, A is for azithromycin, which is macrolides, and T is for tetracyclines. However, this initiation, it's not the mechanism of action of macrolides, although they do bind to 50S. So macrolides is the correct drug, but this is not the correct mechanism of action, and we're going to see right now. So basically, protein synthesis inhibitors, they inhibit protein synthesis by binding to the ribosomes at either the 30S subunit or the 50S subunit, okay? And how should we know which drug binds where? So there's this nice mnemonic. It says bind at 30 and sell at 50. And then we have this extra drug that's not part of first aid or any other place. So at, A stands for aminoglycosides, and T stands for tetracyclines. So aminoglycosides and tetracyclines both bind at the 30S subunit, okay? And then we have clindamycin, chloramphenicol, erythromycin E, which is basically macrolides, and linezolid. They bind at 50S at the 50S subunit, plus quinopristine, dalfapristine also binds to the 50S subunit, okay? And almost all of them are involved in inhibiting the elongation of the protein. However, aminoglycosides and linezolids are the only ones that are going to inhibit the initiation complex. And therefore, they're bactericidal. So aminoglycosides, linezolid, by inhibiting initiation, they become bactericidal, while the others are only bacteriostatic, okay? So basically, if we go here, binding at 30S ribosomal subunit inhibiting initiation, what drug would this be? Binds at 30, so it's
aminoglycosides.
Yes, aminoglycosides. And binding at penicillin binding protein, this is definitely one of the beta-lactams. Binding at 50S subunit inhibiting the initiation, this is
Linezolid.
Yes, it is linezolid. So linezolid and aminoglycosides are the only ones with initiation. However, linezolid is in 50S. Aminoglycoside is at 30S, okay? And then binding at 30S to inhibit the elongation. This is tetracyclines, okay? So we're gonna sprint through all the protein synthesis inhibitor quickly. Macrolides, yes, inhibit translocation. Therefore, it's gonna inhibit the elongation part of the protein. Not the initiation, but it's the elongation of the protein. So aminoglycosides, if you know gnats are basically these flies, kind of weird insects anyhow. So gnats to stand for gentamicin, neomycin, amikacin, tobramycin, and streptomycin. So these are the drugs that are under the aminoglycoside class, and they cannot kill anaerobes, okay? So basically, aminoglycosides has no coverage over anaerobes. It has coverage over aerobes like Pseudomonas aeruginosa, and also we're going to see right now why. And cannot here, the NNOT stands for the side effects of the aminoglycoside, which are nephrotoxicity and neuromuscular blockade, which is very important because a person who has myasthenia gravis and you give them aminoglycosides, they're going to have like worsening of their condition, and therefore it's an absolute contraindication to give aminoglycosides, which have neuromuscular blocking side effects, to a person with myasthenia gravis. So in a question, if it comes and someone has myasthenia gravis, make sure to never give aminoglycosides. The other side effect is ototoxicity, and the other one is teratogenicity, so you do not give it in pregnancy. And nephrotoxicity and ototoxicity are both also side effects of what other drug from the cell wall synthesis inhibitors?
Vancomycin.
Yes, vancomycin. Vancomycin also has nephro and ototoxicity, okay? So we know now gnats cannot, this is the side effects, and they cannot kill anaerobes. And why is that? So aminoglycosides, they require porins, which are present in which type of bacteria? They're present in the gram-negative bacteria, right? So they can only kill gram-negative bacteria because they can only enter there. And also they need oxygen for the uptake. So they cannot work against anaerobes because anaerobes will not use oxygen. So basically, aminoglycosides are kind of ineffective against gram-positive because there are no porins and anaerobes. And they have better effects, synergistic effects, if given with beta-lactams, okay? And they're always IM or IV, never oral because they cannot get absorbed. So aminoglycosides are not given orally, they're only IM or IV. And since they cannot cross the blood-brain barrier, they cannot be used in meningitis, okay? And something very nice about aminoglycosides is that they have something called the post-antibiotic effect, which means that basically, even if you give them a dose, even if the concentrations in the blood of the drug went down, it will still have an effect, and therefore allowing the drug to be given only once daily, okay? So this is for aminoglycosides. For tetracyclines, they are minocycline, doxycycline, and tigecycline is a derivative of tetracycline. It's not exactly it, but in your lecture, it was the same. So tetracyclines, they're effective against all bacilli. It's effective against all the bacilli, whether gram-positive or gram-negative, and also effective against anaerobes, which is nice, and atypical bacteria. And we already mentioned this, that fat, fluoroquinolones, azithro, which is macrolides, and tetracyclines can be used for the atypical bacteria like mycoplasma and chlamydia, for example. Side effects of tetracyclines, one of the most important one is that they chelate calcium, and calcium is needed for teeth and bones. So if you take tetracyclines, they're going to cause discoloration of the teeth or enamel hypoplasia, and therefore, you can kind of remember it instead of reading it as tetracycline, tetracyclines. So yeah, and also since they have these effects, you cannot give it to pregnant women or children under 8 years old because it's going to affect their teeth and bone growth, and therefore it's teratogenic. And also another one is phototoxicity. Phototoxicity, how I remember this is, although they didn't mention it to you, but doxycycline is sometimes used as an acne medication. And I'd like to remember anything that you use as acne topical will cause you phototoxicity because they'll always be like, don't go into the sun, use sunscreen, and so on. So tetracyclines, teeth and bone, because they chelate calcium, and GI distress, which is almost with any drug, and phototoxicity. And since they chelate calcium and so on, their absorption and the absorption of the food is going to be affected if you take the drug with food and milk and antacids. So basically, they're not recommended to take with food, milk, and antacids, okay? And another thing is that tetracyclines, they are all contraindicated in renal impairment. So pregnancy and children below 8 and renal impairment, except doxycycline. If you remember, Momo showed a table where doxycycline is can be eliminated. It's eliminated hepatically. So in renal impairment, it's fine to use doxy. And this is dumb, but doxy is not toxic to the kidney, so it's fine to take even if there is renal impairment. And as we said, pregnancy and children below 8. For chloramphenicol, chloramphenicol is a drug that's not very used. It's cheap and very effective, but it has a lot of side effects. And so it's reserved only when there is like very severe cases of meningitis, since it crosses the blood-brain barrier, or like just eye drops, eye ointment, okay? And the very important side effect, which is if they're going to ask you about chloramphenicol, they're going to ask you about the aplastic anemia that's associated with chloramphenicol. And this aplastic anemia is not dependent on the dose. It can happen anytime. Yeah, basically can happen even with the least dose, and you don't know who's going to get it and who's not going to get it. So that's why it's not really used, and it's very severe and it's very fatal. The aplastic anemia associated with chloramphenicol. and it has another side effect, which is just normal myelosuppression or anemia. This is dose dependent. The aplastic is not, okay? And then the last thing is gray baby syndrome, and this is because chloramphenicol is going to accumulate because it needs to be metabolized by the liver, and the enzymes, UDP, whatever this is kind of immature in the neonates, and therefore when chloramphenicol accumulates, and they're going to have gray baby syndrome. So chloramphenicol, most likely 2 questions you're going to be asked about, either the aplastic anemia or the gray baby syndrome. Okay. I think, no, wait, I don't think they're the last, but clindamycin. Clindamycin is used to treat anaerobic infections, and how they want to say it is that clindamycin for anaerobic above the diaphragm, and clindamycin for above the diaphragm, and metronidazole for under the diaphragm. Okay, and also can be used to treat acne. I think if you've ever gone to the dermatologist, they're gonna give you clindamycin for topical use for acne. And since it kills anaerobes, Bacteroides fragilis, which is one of our gut bacteria that are anaerobes, if it kills them, there's no longer competition, and what can come in? Clostridium difficile, and therefore you're going to get pseudomembranous colitis. So a very, very important side effect of clindamycin, again, one of the drugs which I think they're going to ask you about the side effect, is clindamycin causing Clostridium difficile pseudomembranous colitis. Then macrolides, which are erythro, clarithrol, and azithro. And again, they are going to treat atypical pneumonia and every other type, gram-positive cocci, gram-positive bacilli. It has a lot of things, but it's important for atypical. Again, fat here. And their side effects, think of the MAC part of macrolides. So gastrointestinal motility issues, arrhythmias caused by prolonged QT. This is very important. You're going to learn later another drug, which fluoroquinolones will say also prolongs QT interval, so you cannot use them together, okay? And then cholestatic hepatitis and GI stuff and so on. And very important, what is this? Okay, very important is that clarithromycin and erythromycin, not azithro, only clarithrol and erythro inhibit cytochrome P450, and the first letter is C and the last letter is E. I don't know how that's going to help you remember, but yeah, clarithrol and erythro inhibit. The last thing, linezolid is effective against MRSA and vancomycin resistant enterococci also. So it's usually a backup drug since it's effective against both. And nice about it is that it's used orally. Vancomycin, if you remember, is IV. Linezolid can be used orally. Okay, sorry. And it causes bone marrow suppression, especially thrombocytopenia. This is important to know. Linezolid, thrombocytopenia, and serotonin syndrome. Okay, serotonin syndrome, thrombocytopenia, side effects of linezolid, and it can kill MRSA and VRE. The last drug, which is quinopristine, dalfapristine, there are actually 2 drugs that work together in a synergistic manner, and they are effective against MRSA, VRSA, and VRE. However, they are only IV. So linezolid is oral, but quinopristine, dalfapristine are only IV. And their side effects, therefore, are going to be IV site, like infusion site related, like pain or so on, and myalgia. And quinopristine, dalfapristine inhibit CYP3A4. Okay. So yeah. So now another question. If you guys have any question before that, you can let me know. I'll read the chats quickly. The fat pneumonic, no, atypical in general. So even chlamydia infections, STD, you can use azithromycin, for example, or tetracycline, like doxy or something. Parmomycin is an aminoglycoside used orally. Okay, this is nice. I did not know that. So parmomycin is an aminoglycoside that can be used orally for the treatment of protozoal infection. Okay, but the rest of the aminoglycosides are IV. Okay. Do you guys have any questions? Sure. Okay. Yeah, you can answer the question. B. Okay. So it seems everyone is saying B. Why is it not A? Or what's happening in general? Okay. So yeah. So yes. Okay. Yeah. So basically, this person, they took clindamycin for prophylaxis, and then ended up getting the C. difficile infection. And for basically for this infection, you can use vancomycin, but orally, because although vancomycin is usually, it's always not absorbed by the gut. In this situation, you want it to work in the gut, and therefore you give it orally and not IV. In other situations, you're gonna give it IV. Okay, perfect. Another question. Which of the following is an oral agent against VRE? C. Okay, perfect. Yes. Because quinopristine, dalfapristine is IV and not oral. Azithro is not, it's for atypical. Chloramphenicol is severe meningitis, but usually not used because of the toxicity, aplastic anemia. Okay. Done here. Momo, if you guys have any questions?
Okay. Yeah, it's okay. Just a second. Okay. So wait, this is mine, right? Yeah. Which adverse effect is most common with sulfonamides? So we're moving on to the this lecture now. Okay. C. Does anyone have another answer? Okay, yes. I think most of you answered C. The answer is E for skin rash, and I'll explain why. Because I know in your slides it says both kernicterus in newborn and skin rash. It's a good thing that you guys know that it can also cause kernicterus, because you're right. But the most common with sulfonamides is skin rash. So wait, can you go to the next slide? For example, like these, photosensitivity, skin rash is the most common side effect of sulfonamide. So that's what I wanted you guys to know, because kernicterus can happen, but it's also very rare in also only in newborns, right? Not in everyone you use. So that's why. Does this make sense? Like, is this clear for everyone? Okay. Yeah, I know. Okay, that's good. So just remember that it's more common. That's why the question asked. Okay, so for the next question, a 32-year-old male presents to an outpatient clinic with a 5-day history of productive cough, purulent sputum, and shortness of breath. He is diagnosed with community-acquired pneumonia. It is noted that this patient has a severe ampicillin allergy and cause anaphylaxis. Which of the following would be an acceptable treatment for this patient? Okay, 2 people said A. Okay, why not B, for example? Because they're from the same class, right? I just want to make sure, why. Okay, B doesn't cover pneumo. Okay, good. So wait, can you show the answer for this one? So good job. The answer is A. Levofloxacin treats all organisms that cause pneumonia. Yeah. So fluoroquinolones, under fluoroquinolones, we have separate different 2 classes mainly, right? So if you can remember, one of them covers, for example, a respiratory, pneumonia, and so on. The other, like how Dr. Dilip, I think, taught it to us in 2nd year, was that he used to tell us levofloxacin, I think the other one was midofloxacin, something like that. They're all respiratory fluoroquinolones. Ciprofloxacin is used for mainly things like UTIs, but they're not respiratory, for not respiratory reasons like pneumonia. And C, for example, the important thing about C in this question is that if a person is allergic to ampicillin, you should not give penicillin at all, because, or cephalosporins in general, because there can be a cross allergic reaction, right? If you remember that. So wait, if you go to the next slide, there's the explanation for this one, which all of you said correctly. You can see here, for example, yeah, so there are different generations. Second generation ciprofloxacin does not cover pneumonia, but third generation levofloxacin does. And I like to think of them as one is like for respiratory, the other is non-respiratory fluoroquinolones. Is that clear for everyone? So just know this slide, it's very important for like overall. Okay. Even
Okay.
gemifloxacin covers. Yeah. Okay, good. Okay, next question. Combination, oh wait, this is kind of easy, but combination of sulfonamides with trimethoprim does what? Which of the following? Okay, one person said B. Does anyone have other answers? So this question here, like I wanted, it's a very important concept, right? I know you probably know. I'll explain after this too the mechanism of action of both sulfonamides and trimethoprim, but it's important to know why we give them together, like administer, like and give it together to the patient. I mean. Does anyone have other answers or because there's only one.
Both of
Okay.
them alone, each one
Yeah, yeah,
individually is static, and both of them together become sided.
yeah, good. So that's the main idea that I wanted to get across. Both of them together, like he said, is bactericidal. So it kills the bacteria instead of inhibiting their growth. The answer is B. So as everyone said, it increases the antimicrobial activity. How it does that is by a synergistic effect, if you guys remember, because sulfonamides, basically, this is a picture from your slide, sulfonamides inhibit an enzyme above the trimethoprim in the same pathway, right? So if you give them together, it increases the antimicrobial activity by because it's like affecting more of the bacteria, basically. It's killing them more. Um, Again, sulfonamides act on dihydropteroate synthetase, trimethoprim, the second one. I used to remember it like it always used to inhibit the reductase one, which is the second one. And yeah, that's basically it. Just know the mechanism of action for these two and why we give them together. Okay. Does that like is everything clear so far? Okay. One thing I wanted to mention, yeah, so bacteriostatic is when we give one of them only, which means it inhibits their growth. Again, same thing. So if we give them together, it kills the bacteria instead. It's much more harmful to the bacteria. Okay. Yeah, we can move on to the next. Which statement about fluoroquinolones is accurate? So these are all kind of like properties of fluoroquinolones, but only one of them is right. Okay, the others are the like the opposite. Okay, people said D. D. Okay, so I know it's a very long, like there's a lot of things to remember about fluoroquinolones, right? Let's go step by step and then we can see if D is the answer or not. So A, antacids increase their oral bioavailability. Is that true or false? Can you take, for example, fluoroquinolones with antacid? I don't know if this was mentioned, but I remember it being in the lecture somewhere. Okay, just say whatever you think. Okay, no, you can't. Good. So you can't give them together, right? That's why they don't increase oral bioavailability, it decreases oral bioavailability. That's what this sentence means, okay? Second, contraindications of fluoroquinolones. What are the contraindications of fluoroquinolones, and is hepatic dysfunction one of them? Can anyone answer this one? There's like what?
You can unmute yourself if that's easier.
Yeah, if that's easier, because I know it's not. Okay, yeah, contraindications. The main contraindications for fluoroquinolones is you can't give it to children, anyone under 18, or elderly because good job. So because it causes tendinitis, and like it's usually not the first line treatment at all in elderly or children. So you can cross out by this thinking that C is wrong. And B is also wrong because you can give it's fine to give, like it's not hepatically excreted, so it's okay. D, okay, wait, yeah. So D, like you said, is correct. You can show the answer, but basically the mechanism of action of fluoroquinolones is on DNA gyrase, right? So that's why one of the resistance methods from the bacteria to fluoroquinolones is changes in the enzyme or the site of action. So DNA gyrase, also called topoisomerase, if you remember. So if there's a mutation in these, the drug fluoroquinolone won't be able to act on them, won't be able to act on the bacteria because their site of action is not correct. Okay, so I think it's okay. Even wait, modification, even renal was not an indication for contraindication for fluoroquinolones, if I'm not wrong. So D is the most correct answer in this case. So yeah. So whoever said D, that's really good. So these are the mechanism of resistance to fluoroquinolones. So whatever fluoroquinolones act on, which is DNA gyrase enzyme, topoisomerase, if there's a mutation of these enzymes, they can't attach to them, they can't work on the bacteria. Another method is called efflux pump. So basically they pump the drug out. That's the second kind of resistance mechanism against fluoroquinolones. Third one is permeability. So it can't enter at all in the bacteria, which causes resistance. So can't enter, exits, I guess, if you can remember, and it doesn't attach, right? So these three are the mechanism of resistance to fluoroquinolone. Is everything clear for the question? I know it was a long one. Okay, good. So if you have any questions, feel free to write or stop me anytime, okay? Or write in the chat. Okay. I think we can move on. Yeah. Okay, so a 14-year-old boy returns from a Boy Scout backpack trip with foul-smelling watery diarrhea. On further questioning, he admits to drinking water from a mountain brook without boiling it first. Stool is sent for ova and parasites. He is eventually diagnosed with a Giardia lamblia infection. I never could pronounce it. Okay, which of the following drugs is the most appropriate treatment? It's very good. You guys are all saying B. This is also from your microbiology lectures, but it's very important you know what is used to treat Giardia. Wait, Shamiaa, how do you pronounce it? I don't know if I'm saying it right. Giardia?
I don't know. I say Giardia, but I don't know.
Okay. So this parasite, basically the first line treatment is always metronidazole. Can you go to the next slide? One way you can remember this is from Sketchy. I don't know if you watched this one yet, but I used to always use Sketchy for micro, and the drugs for each parasite bacteria helped me so much in the exam. So you can see here, I can't point to it because it's on my screen, but the train is metro, right? And the up there. So it's metronidazole is the first line for Giardia. From this picture, Giardia jungle, right? But yeah, even without the name of the parasite. You can tell foul-smelling stool from a hiking trip. Those are keywords for this parasite. Okay, is everything clear? Okay, good. So there, I have a slide on metronidazole, how it works, and side effects. So we'll come to that too. It's a very important drug in parasites mainly. Okay. Which of the following agents is available as an oral therapy for the treatment of visceral leishmaniasis? So another one. You can start, yeah. And yeah, okay. B, someone said. Try to cross out things that, yeah, B. So good job. The answer is B. You can, yeah, there you go, miltefosine. Now A, do you know what A is used for? Like usually what we use A for? Artemether, we give them as a combo, mainly. Yeah, it's not okay, it's not with you. It's fine. It's for malaria. I just thought I remember seeing it in micro in our lectures maybe, but my bad. Yeah. So if you didn't take it, just cross it out immediately. B is right. It's usually for visceral leishmaniasis. Again, nitazoxanide, I don't remember taking them either. Tinidazole is I used to always think of metronidazole, right? The ending are the same. So metronidazole is not the first line for visceral leishmaniasis. It's for things like giardia or histolytica and so on. So that's why. So B is the right answer. If there's another, I have a slide for that too. Yeah, here. So this is a picture from your slide, and it's mainly used to treat again leishmaniasis and free-living amoeba such as Naegleria fowleri, and it's the first drug to be taken orally. All of them, by the way, the ones before they can be taken orally, but since it's not relevant to leishmaniasis, this is the most correct answer. Is that clear for everyone? Okay, good. Now, again, another one. The preferred treatment that a patient should receive for the initial symptoms of diarrhea due to a protozoal infection, which were indicative of mild to moderate disease, is which of the following? Someone said A, D. Okay, good. I want you like all to think like what, because there's a slide in your lecture that wasn't in ours, like we never knew about this. D. Okay. Okay, we can show the answer, but the answer, like whoever said D is right. I'll explain why not A. Basically, the symptom of this person, the patient is showing symptoms of diarrhea, right, due to protozoal infection. There's a certain like protocol like we all have to follow for patients who are asymptomatic, for patients who are showing symptoms, for patients with severe diseases. If you go to the next slide, there's a table. So I just wanted you guys to remember this, because if a patient is asymptomatic, you can use A alone, which is diloxanide furoate. It's fine to use it alone. You don't have to have it together with any other drug because again, it's asymptomatic. It's like the least amount of medication you can use it if you want to think like that. Or paromomycin. If the patient is coming with diarrhea or dysentery, which means bloody diarrhea, you should use it together. So metronidazole is a must, or you combine it with diloxanide or paromomycin. They're both fine. In the question before, it was this combination, the one in the red box. Amoebic liver, yeah, here you go. So that's why. Amoebic liver abscess, which this patient did not show, you have to use the other one, which is chloroquinolone plus metronidazole. So if you want to think about it, the worse the symptoms are, you have to add more drugs to it, right? Does this make sense? Does it make sense why it's not A alone? Okay, good. Yeah, we can go on. So this is also very important. The following precautions should be advised to the patient while prescribing metronidazole. Which of the following? Okay. So this, yeah. Okay. D. Good. So D is the right answer, and I'm really glad you got it on the, like, when I first showed the question. So basically, when you're giving metronidazole to someone, can you go to the next slide? I'll explain it there. So yeah, this is the mechanism of action of metronidazole. Wait. I don't know if it was explained to you in details, but in the lecture, I mean, but this is a picture from there exactly. Metronidazole acts mainly by free radical formation and so on, which acts on DNA and damages them of the bacteria of the parasite mainly. Can you click? There's something, yeah. So adverse effects for metronidazole are very important. You should know that one of the adverse effects that they always used to tell us was metallic taste. It's like not the patient won't feel comfortable with that if you get what I mean. So I used to memorize it by that, metallic taste and dry mouth. And another one is peripheral neuritis, which wasn't in the question, the choices. The only one that was there, which made sense and was relevant, was avoiding alcohol. So again, if alcohol is taken, like someone takes alcohol and is taking metronidazole at the same time, it causes disulfiram-like effects, which is very, very, like, you should completely avoid that. And I think it makes the symptoms of like alcohol very very much worse. That's all. Peripheral neuritis is again the most serious. If you see that in an option for metronidazole, choose that because it's one of the most serious side effects. In a different question, of course, like not this one. But yeah, so people should avoid alcohol with metronidazole. Is that clear for everyone? Okay, good. It's good you all got that. Okay. Okay. Oh, is this yours?
Yes.
Yeah, okay.
Okay, so a 48-year-old immigrant from Mexico presents with seizures and other neurologic symptoms. Eggs of Teniasolium are found upon examination of a stool specimen. A magnetic resonance image of the brain shows many cysts, some which are calcified. Which of the following drugs would be of benefit to this individual? Okay, I see 2 C's. Any other answers? Okay, another C. Okay. So I'm gonna give you the answer because I already did. But yeah, so the answer is C, albendazole. So basically what happened to this patient is that he has neurocysticercosis. And right now we're going to see the drugs and what they're used for, but none of these drugs are the first drug of choice for neurocysticercosis. It's albendazole, okay? So antihelminthic drugs, as we know, there are 2 types of helminths. We have nematodes and the platyhelminths, which are the flatworms. For nematodes or roundworms, these are the drugs that are used in it: albendazole, mebendazole, which is from the same class, pyrantopamoate, and diethylcarbamazine, and ivermectin. For platyhelminths, again, they're divided into 2 parts, which is cestodes and trematodes. Cestodes, which are the tapeworms, segmented, ces for segmented. So it has niclosamide as the first, what is it? Okay, so it has niclosamide as the first drug of choice, and then praziquantel. And sometimes we use albendazole depending on the situation, which we're going to see. And then for trematodes, we have praziquantel as the first, and then niclosamide, okay? So we're going to move on. So the first class, which is benzimidazoles, they have albendazoles and mebendazoles. They have bend in it for benzimidazoles. And basically how they work is inhibiting microtubule polymerization in the cell. And how do they inhibit the microtubule polymerization? They bind to beta, this mouse is gonna annoy me. They bind to the beta tubulin, okay? This is dumb and you're gonna see a lot of dumb mnemonics right now, but beta tubulin, right? Okay, so they bind to beta tubulin or beta tubulin, and this is going to inhibit the polymerization. And now this polymerization is mainly needed for the glucose uptake, microtubule dependent glucose uptake. You have less microtubule, you have less glucose, you have less ATP production and more energy depletion. Again, this is very dumb. You bend when you're tired, basically because you're depleted of energy. So yeah, there are other ways which they inhibit mobilization, mitochondria, and those all, but this was the most important one, which is dependent, which is the glucose uptake. Okay, and albendazoles are very nice drugs. They can be used in all roundworm infection. And this one specifically, which is albendazole, can also be used in tissue infections. Tissue like hydatid cyst and cysticercosis. Although hydatid cyst, which is from Echinococcus, and cysticercosis, which is from Taenia solium, they're not roundworms, albendazole is still the first drug of choice as their tissue infections, okay? So it's the first drug of choice in ascariasis, trichuriasis, which is the whipworm, and hydatid cyst and cysticercosis, okay? Side effects, GI, always think of GI. However, albendazole has elevated liver enzymes and neutropenia or pancytopenia. Maybe pan is also albendazole, right? Okay, so pancytopenia and elevated liver enzymes. And it's contraindicated in pregnancy, especially in the first trimester, okay? And you'll realize that almost all antihelminthic drugs are contraindicated in pregnancy, especially in the first trimester. Then our next drug, which is pyrantyl pamoate. Pyrantyl pamoate works by increasing acetylcholine release and also inhibiting acetylcholine esterase. In this way, there's a high concentration of acetylcholine in the synaptic membrane, which is going to cause persistent activation of the receptors, and therefore you're going to have paralysis of the helminth. So basically, it's like a neuromuscular blocking agent, okay? And this one is the drug of choice in Enterobius vermicularis, which is the pinworm, the one in children. So pyrantyl pamoate for Enterobius vermicularis can be used for ascaris, however, in conjunction with albendazole, not on its own. Okay. Again, a very dumb thing. I entered for Enterobius and then PAM, I was paralyzed. Pyrantyl pamoate. Okay. So yeah. And basically, again, the adverse effects, GI, always think of GI, headaches, drowsiness, it's with all. And the contraindications are severe liver disease and pregnancy, again, especially first trimester, okay? So here it's pregnancy, here it's severe liver disease, okay? Enterobius vermicularis, ascaris, tissue things. Then we have diethylcarbamazine. Diethylcarbamazine, which the short form for it is DEC. It immobilizes microfilariae. So when it immobilizes microfilariae, and then it changes their structure, makes them fall from the tissue and expose them to the immune system, okay? And by exposing them to the immune system, now we can attack it and kill it, okay, by phagocytosis. Since it immobilizes microfilariae, then it's the drug of choice for filariasis, okay? And we didn't really take the, in micro, the filariasis worms. So yeah, that's why I only put filariasis, but it's Wisteria or something like that. A very, very, very important side effect of diethylcarbamazine is Mazzotti reactions, okay? Mazzotti reaction is basically when the filariae die, the microfilariae die, and then after that, there's a very important immune reaction, which causes all these symptoms. Every plate is affected. Fever, the GI, the respiratory, muscles, eyes, brain, kidneys, everything is affected, okay? And therefore, when you're giving diethylcarbamazine, you should give with it antihistamines at the same time, diphenhydramine, okay? Now, this is, again, a very dumb way to remember DEC, which is basically think about it as if it's like there's a micro deck in which the microfilariae, now they jump and they're exposed to the outer world, then exposed to the immune system, and now they get attacked. Okay. Then we have ivermectin. So ivermectin binds to glutamate-gated chloride channels. Now, when they open, they increase the chloride permeability, and when chloride, which is a negative ion, goes in, the cell becomes hyperpolarized, and now it's harder for it to form an action potential, and therefore paralysis of the cells again. Okay. Now, ivermectin is the drug of choice in river blindness. Iver for river, okay, which is onchocerciasis. So that's very easy. If you get a case of onchocerciasis, the drug of choice is ivermectin. Okay. The adverse effects include seizures and increased liver enzymes, and they can cause Mazotti reactions too, just like DEC, but much lower. So they also have reactions to the dying microfilariae, but might be to a lesser extent than DEC. And they're contraindicated in children as it increases the risk of CNS effects, which we said because they cause seizures. Another drug that's a beta-lactam that causes seizures is imipenem, right? They both start with I, so maybe you can remember that. So yeah. And pregnancy again, first trimester pregnancy again. Okay, so these were for the roundworms. Now for the flatworms, we have niclosamide. Niclosamide inhibits glucose uptake. Albendazole inhibits microtubule dependent glucose uptake. This inhibits glucose uptake, leading to depletion of ATP. Okay, and therefore the sections that are most affected, the scolex, which is like the head part, and the segments, but the ova, which do not need this energy, are not going to be affected. Okay, and therefore if you only use niclosamide, the ova are going to remain in the gut, and if the ova remain in the gut, say for example it was a Taenia solium ova, it can now cause cysticercosis. So you're not supposed to leave it in the gut, and that's why you should give laxatives or purgatives to remove the dying the dying larvae and the ova and so on, to prevent the cysticercosis. Okay, and niclosamide is the drug of choice in cestodes, so tapeworms. However, as we mentioned, cysticercosis and hydatid cysts, their drug of choice is albendazole, okay, because now they're tissue infections and they're no longer in the lumen. And the adverse effect is GI disturbance. And the last drug, which is praziquantel. So praziquantel is a drug that has two mechanisms of action. So at low doses, it's going to increase the cell permeability to calcium, leading to spastic paralysis, basically. And maybe you can represent the Qua with Ca, so praziquantel, Ca for calcium, okay? And at high doses, it causes tegmental damage. I tried finding what tegument is, but I'm not sure exactly what it is. But basically, when it causes the damage to this tegument, this is going to activate our immune system to destroy the whatever it is, the worm, okay? And again, instead of saying praziquantel, you can say praziquantel. So at low doses, it's calcium. At higher doses, it also causes tegmental damage. And this is the drug of choice in schistosomiasis. So niclosamide for cestodes, praziquantel for schistosoma, okay? And the dying worms can also cause a low-grade fever and rash. And this is one of the side effects, but it's not to the extent of the Mazotti reaction. And their adverse effects include the GI and headaches and nausea and whatever, all the side effects that are always there. But importantly, cardiac arrhythmias, okay? And maybe it's related to calcium, but basically it causes cardiac arrhythmias, and that's why it's contraindicated to use in arrhythmias or use it in caution with arrhythmias. And another contraindication is ocular cysticercosis, because when you kill the cysticercosis there, it's going to cause permanent eye damage and permanent blindness, okay? However, this is the first drug that is safe in pregnancy. Praziquantel is safe in pregnancy. The others are contraindicated in pregnancy, okay? So there's a question, is albendazole for neurocysticercosis or specifically? No, for cysticercosis in general. Albendazole for cysticercosis and hydatid. Okay, so yeah. So now, do you guys have any questions? related to this? Or I'm gonna move. Okay, so this is the question. A non-indigenous person who develops onchocerc cases in an endemic region receives treatment is likely to receive experience a severe reaction. Ya Allah. Symptoms include headache, weakness, muscle aches, hypertension, and peripheral edema. Which statement concerning this reaction is accurate? I'll pretend you guys did not see that. Okay, if you're gonna say D, why is it not E? Why not
Onchocerca is treated with ivermectin.
Okay. Wait. So yeah. So this is Mazzotti reaction, which is due to the dying microfilariae. Okay. Another one. What is the drug of choice in treatment of schistosomiasis? Praziquantel. Okay. Niclosamide is the drug of choice for tinea, cystodes, yeah. Except cysticercosis and hydatid cyst. Albendazole is the drug of choice for everything tissue and so like cysticercosis, hydatid, yeah, and the last one, the very important one, big, large worms. Ascaris, okay. And ivermectin, we said, is for onchocerca, praziquantel for schistosoma, pyrantel palmate for pyrantel palmate hook. Yes, vermicularis, it's Enterobius vermicularis, the pinworm. That's the pyrantel is the drug of choice. And diethyl carbamazine filariasis. Yes, okay. Bancroftu, okay. Yes, Wertschieria, that weird names. Yeah, filariasis, okay.
Wait, I wanted to add something for the last one here. This one, there's this. I never use sketchy pharma, but like there's a pretzel, like a picture of a pretzel near schistosomiasis. So it helps, like praziquantel is like pretzel. I don't know. It's it's just a way to memorize the name itself. So yeah, that's all I wanted to add.
Thank you so much.
Yeah.
So yeah, next question. Do you guys have any questions related to antihelminthic drugs? Oh, good. Okay. So this question, what is the drug of choice to treat onychomycosis? Which is basically the nails, onycho for nails. Difficult question. Okay, someone said A. Someone said D. Two people said B. Anyone has any other answer? Okay, someone just said no, not B. Okay, what other than B? Okay, someone says I think it's C. Okay, another person says CC. Okay, so the answer is C, yeah. So basically we're going to see now, but the drug of choice for onychomycosis is terbinafine. Amphotericin is usually for the severe invasive candidiasis aspergillosis, like disseminated fungal infections. And we're going to see right now everything. So antifungal drugs in general, they work either by ultimately inhibiting ergosterol. We have cholesterol in our cell membranes. Fungus have ergosterol, okay? And this is important for the integrity of the cell membrane, okay? So the fungal cell can, the antifungals can either inhibit directly the formation of ergosterol from nonesterol by inhibiting this enzyme, 14-alpha demethylase, okay? 14-alpha demethylase, and this enzyme is inhibited by the azoles, okay? Which we're going to talk more about later. Then we have either basically inhibiting the formation of this nonesterol by inhibiting the conversion from squalene, and this drug is terbinafine. It inhibits squalene epoxidase. So terbinafine is going to inhibit the formation of ergosterol and accumulate squalene, which is also deadly to the cell. So we're going to see that. And then we have the inhibition of the cell wall itself. Cell wall is by a class of drug called echinocandins. And echinocandins, the drug is caspofungins. They end with fungin. And then basically at the ergosterol itself binds to the ergosterol and causes spores. This is by polines, which are amphotericin B and nystatin. And then for the nucleic acid synthesis, we have flucytosine, okay, which is going to inhibit the nucleus, and we're going to go into each of them. So starting with amphotericin, we said it binds to the ergosterol, and this forms large pores. This is going to disrupt the balance of the cell and permeability in what's so not, and ultimately is going to lead to the cell death, okay? But amphotericin and this is for amphotericin and nystatin, they're both polines. They're in general very toxic and have a narrow therapeutic index. And so they have to always be monitored, okay? And amphotericin is always given IV, okay? And it's not water soluble, and therefore you have to give it in formulations with lipids and so on, okay? So this is used in cases of severe disseminated fungal infections. It's toxic, right? And it has a narrow therapeutic index. So you don't use it in the beginning with small infections like just a nail infection or onychomycosis. It's only going to be used when you have a severe systemic infection, okay? Like candida and aspergillosis, okay? And since it binds to ergosterol, we said we have cholesterol in our membranes. So although to a lesser extent, it can still bind to our cholesterol, specifically in the kidney. And when it binds to there, it's going to cause problems in the permeability in the kidney. And that's going to affect their renal flow and cause nephrotoxicity. So you can remember that as amphotericin instead of amphotericin. So that should help you remember that it causes nephrotoxicity by disrupting the permeability of the cursor is annoying me. Sorry, one second. Okay. By affecting the permeability of the kidney. Then we have nystatin. So nystatin is the other polyene, but it's much, much more toxic than amphotericin. So it will never be used systemically, okay? It can be used in topically as swish swash, basically for oral candidiasis. You take it, you move it around your mouth, and then you spit it out. So that's for nystatin. Maybe you can remember it because nystatin kind of sounds like nice tasting, right? Tastes nice, you put it in the mouth, swish swash, and then throw it out, okay? So yeah, it's very toxic, so you don't do that. And then it causes nephrotoxicity, so of course it's contraindicated in renal dysfunction. It causes problems in the permeability, so of course it's contraindicated in electrolyte imbalance, and it's contraindicated in pregnancy, okay? Then we have azoles, which we said inhibits the synthesis of ergosterol. Amphotericin binds to ergosterol. This inhibits the synthesis of ergosterol, okay? And that is by the means of inhibiting 14-alpha demethylase, okay? And this is going to disrupt the membrane integrity and what so on and lead to cell death, okay? And since it's going to inhibit that, it's also going to inhibit the yeast changing into hyphae, okay? And azoles themselves are divided into two things, imidazoles and triazoles, okay? And imidazoles are ketoconazole and clotrimazole, ketoconazole and clotrimazole, CACA. They are imidazoles, which can be used either orally or topically. And I like to remember this as in it's imidazole, so it can be used immediately. You can either just put it in your mouth or topically. However, triazoles, they can be given IV, so orally or IV. IV is not an immediate thing that you can do, okay? And triazoles are fluconazole. So two in imidazoles, which are the CACA ones, ketoconazole and clotrimazole, okay? Oral and topical. And basically, azoles are usually used in athletes' foods. Yes, they can be used in onychomycosis and ringworm, but we're gonna see that the drug of choice is terbinafine in a while, okay? So basically, clotrimazole is used only topically. Here, it's only used topically, and it can be used for vaginal infections, candidiasis, oral, diaper rash, and athlete's foot. This is kind of, I don't know if I should say, but basically clotri kind of sounds like clitoris, so maybe you can remember it for vaginal infection. Ketoconazole is used orally, so systemic infections, but it can cause liver toxicity. So this is for lesser severe infections. And fluconazole is used for fungal meningitis, okay? So yeah. And then we have the last three ones, which is echinocandins. So echinocandins, we said, is capsofungin. The drug is capsofungin, and they inhibit something called 1,3-beta-glucan. 1,3-beta-glucan is needed for the cell wall. So if you don't have it, your cell wall is not going to be formed well, and you're going to lose integrity, and the cell will die. Maybe you can remember it as E kinda can't do cell wall. Okay, so basically they cannot form the cell wall because of the inhibition of 1,3-beta-glucans. Okay. For Candida, they're fungicidal. For Aspergillus, they're fungistatic. Okay. So yeah. And they're used in invasive candidiasis and aspergillosis. And the adverse effect is hepatotoxicity, flushing GI. I don't think it's very important to know. Then we have the allylamines, which is terbinafine and naftinafine, which we said inhibit squalene epoxidase. And inhibiting squalene epoxidase, you cannot form ergosterol throughout, and you're also going to accumulate squalene. Both of them are going to lead to the death of the cell, okay? And terbinafine is used topically and orally. So maybe you can, instead of E, it's terbinafine. So TO for topical and OR for orally. They're used both ways, topically and orally. But naftifine is only topically, and they're used in the skin and nails. So basically, this is the drug terbinafine. This is the drug of choice for onychomycosis. Then we have flucytosine, which is an antimetabolite. It's gonna change into 5-fluorouracil by the enzyme cytosine deaminase. 5-flucytosine. Then you remove the cytosine by cytosine deaminase, make it a uracil, so it becomes 5-fluorouracil, and this is in the fungal cell. This is going to inhibit thymidylate synthase, which is going to inhibit DNA synthesis and cell death, basically. And it's mostly 90% of it is excreted renally, so you need to adjust it for renal impairment. And basically, it inhibits DNA synthesis, so you can think that it's going to cause stuff that are similar to chemotherapeutic agents, which is bone marrow suppression, alopecia, and so on. The last one, which is benzofurans. Benz kind of reminds me of benzimidazoles, right? They both have benz, and they both act on the microtubule, right? So basically, it's kind of the same, but this is for fungus, and that's for helminths. The drug is called grisofulvin. It interferes with the function of the microtubule, disrupting mitosis, causing cell death, okay? And this drug is very nice as it concentrates in the keratin cells. So when you have a new skin cell that forms and it has keratin, it's going to be concentrated there. And therefore, it's nice to be in the site of action. So it's going to be used for the skin infections like nails and so. But as we said, terbinafine is the drug of choice for the onychomycosis, but for skin, maybe you can use grisofulvin. Important, it induces, not inhibits, induces CYP450, and it causes all these general side effects, but including photosensitivity, and it's contraindicated in porphyria, hepatic failure, pregnancy, and breastfeeding. This is the first time I see breastfeeding being mentioned. So yeah. So basically, I know this was a lot of information, but yeah, we can move on to the question. If you guys have any questions, you can ask that, or we can ask this. Okay. A patient suffering from invasive aspergillosis is first administered NSAIDs, antihistamines, and adrenal glucocorticoids prior to administration of an antifungal drug. The antifungal drug works by, okay, binding to ergosterol. What drug are you thinking? Amphotericin, okay. What is A? What is A, the drug that binds to tubulins? What's the name of the drug? Echinocandins, Grisophulvin, yeah. Grisophulvin, yes. Benzofurans, okay. Which one inhibits squalene epoxidase? Allylamines, but what's the name of the drugs? Two drugs. Nafti and terbi, yeah. Terbinafine and naftifine. Would capsofungins also work in this question? Most likely yes, but we said that it's fungistatic for aspergillosis and fungicidal for candida, so I would think that amphotericin would be better, since it would kill the aspergillin. Although in the slides it does mention that it's used both for invasive candidiasis and aspergillosis. Okay, which one inhibits thiamine synthesis? Flucytosine. It gets converted to what molecule? Using what enzyme? 5-fluoro. And the enzyme? Cytosine deaminase. Yeah, flucytosine, cytosine deaminase. Okay. And the last one, which one inhibits 14-alpha demethylase? Azoles, yeah. Ketoconazole, fluconazole. Okay, so correct. Binding to ergosterol. Okay, so I'm done with my part. So I think we're done with the antibiotics part. Do you guys have any questions related to the antibiotics? All good? Okay. So we'll move on. So full activation of the parasympathetic nervous system is likely to produce which of the following effects? D. Okay. Okay, perfect. Good. Yeah. So I think this is kind of an easy question. Bronchodilation is sympathetic. Decreased intestinal motility is also sympathetic, and the rest is all sympathetic. Okay. So basically, the autonomic nervous system, just a quick overview, it's either sympathetic or parasympathetic. Sympathetic is thoracolumbar, parasympathetic is craniosacral. Sympathetic and parasympathetic, both of them, the preganglionic is acetylcholine. The preganglionic, or the receptors to the ganglion, both of them, they receive the neurotransmitters as acetylcholine. However, the difference in the postganglionic, which is to the effector, in the sympathetic is norepinephrine or epinephrine, except sweating, which is acetylcholine. When you're scared, you break into a cold sweat. Okay. As for a parasympathetic, it's also again acetylcholine. Sympathetic have adrenergic receptors, parasympathetic have nicotinic and muscarinic receptors. So these are the physiologic effects, and these are so easy to remember if you guys kind of just sit and think about it. So here, for example, the eyes, if you're in a scary situation, your pupils would want to dilate to bring in more light so that you can see better, right? So it dilates pupils, relaxes ciliary muscles, okay? Salivary glands, you don't need to eat anything right now, so it's fight or flight, right? So it inhibits saliva secretion, where here it's rest and digest. Okay, so now I'm going to be eating and relaxing, and so stimulate saliva secretion. The lungs, you need to be able to breathe better and bring in more oxygen. So it's gonna dilate bronchioles in sympathetic. However, in parasympathetic, it's gonna constrict the bronchioles. For the heart, you need more blood, you need more oxygen, and therefore you're going to have increased heart rate in sympathetic. In parasympathetic, they're gonna be decreased. For the sympathetic, you don't need to digest anything right now, decreased motility. However, for parasympathetic, it's rest and digest. So you're going to increase the motility of the GI. Again, you don't need to secrete or digest anything. So decreased secretion here, increased there. For the bladder, right now, you need to hold it off. So it's going to delay the emptying, relax the muscles so that they don't thingy. And the sphincter is going to be constrict so that you don't basically pass urine. And it's the opposite for parasympathetic. For the blood vessels, the sympathetic is going to cause peripheral vasoconstriction and muscle vasodilation. So you see here, the vessels are going to be vasoconstricted in the peripheries. In the muscles, skeletal muscles specifically, there's going to be vasodilation. And that is because you want more blood to reach the skeletal muscles so that you actually have energy if you're running away from something or so on, and increases blood pressure. For parasympathetic, there's no direct receptors on the vessels for the parasympathetic system. However, it can have an effect of vasodilation by producing nitric oxide, okay? Then we have the liver. Here we're going to convert glycogen to glucose, obviously because you want energy. And then for the sweat glands, we said it's going to secrete sweat, however, through acetylcholine. And adrenal glands secrete adrenaline, okay? As for the receptors, for the parasympathetic nervous, we have a system, we have nicotinic and muscarinic. Nicotinic are either NN for ganglionic receptors or CNS receptors, or NM, M for muscle. So skeletal muscle receptors are nicotinic, although this is somatic rather than parasympathetic. It's somatic, but through acetylcholine, neuromuscular junction, NM, okay, nicotinic. For muscarinic, we have M1, M2, M3, M4, and M5. M1 is neural and gastric. However, this is in your lecture. In first aid, it's different. So I think remember it according to your lecture. Sorry, this is okay. So neural and gastric for M1, and this is GQ, which means it works by CAMP or by calcium. What does it work by? GQ. Okay, yeah, by calcium. So M1 is GQ, then M2, which is in the heart and CNS, is by GI, so it inhibits adenylate cyclase, okay? And then we have M3, which is in glandular and smooth muscle cells, and now this is GQ again, okay? So it's QIQ. And then M4 and M5 she doesn't mention, so we don't have to know, okay? So yeah. And for the adrenergic receptors, so they're kind of difficult to remember. So this is kind of a trick or a mnemonic, I don't know what to call it, to remember it. But basically, to remember the locations, alpha, A, is present in the arteries. Beta is present in beats or breaths, heart or lungs, okay? And all of the alpha receptors, all of the beta receptors are GS, which work by CAMP. For the types in action, we have like alpha 1, alpha 2, right? So 1, if the number is 1, it's going to contract. If the number is 2, it's going to dilate. So if you're going to apply it here, then alpha 1 is going to cause vasoconstriction. It's present in the arteries and it's going to contract. It's number 1, okay? Alpha 2 is gonna dilate, okay? And basically how it does that is that basically it's present in the presynaptic presynaptic membranes, and it inhibits the release of norepinephrine. So it's in fact against the sympathetic system. Okay, so alpha-2 is dilation. Then we have beta-1. Beta-1 present in the heart is going to contract. Beta-2 is going to dilate. Okay, and we're going to see here very quickly. So alpha-1, which is GQ, vasoconstriction, mydriasis, constriction of the iris dilator muscles, and this causes the pupil to go bigger. And basically bladder sphincter contraction. For alpha-2, it causes dilation, and we said it inhibits in the presynaptic terminal thing. Then we have for the beta-1, we have one heart, so it's present in the heart. And since it's one, it increases the contraction and increases heart rate. Beta-2, we have two lungs, and therefore it's going to dilate the smooth muscles, like bronchodilation, right? And it's also present in the vessels of the skeletal muscles and causes vasodilation. Then we have beta-3, like triglyceride. This is present in the adipose tissue and causes lipolysis. Okay, so now we can have questions. So which of the following is correct regarding the autonomic nervous system? D. Okay, yes, correct. Okay. Wait. That was not correct. So yeah. So the correct answer is C, because we said that the preganglion, all of them is acetylcholine, whether it's sympathetic or parasympathetic. For this one, afferent neurons carry signals. It's efferent, but we don't. It's not part. Then we have at the ganglion, it's always acetylcholine, whether parasympathetic or sympathetic. So this is the correct answer. Sympathetic neurons, they release norepinephrine or epinephrine, except for sweat. Parasympathetic neurons release norepinephrine. No, they release acetylcholine in the effector organs. Okay. Okay. Which of the following drugs act by blocking choline transport? Any other answers? Okay. Okay. Anyone has any other answer? Or the same answer? Okay. So yeah. So it is B, hemicolinium. And we're gonna see right now. So this is a picture from the slide. So basically here she was trying to show what are the different ways to affect the parasympathetic nervous system. And to be honest, I've never seen these in first aid and so on, but since she had them in green, so we need to know them. So the first one, which is precursor transport blockade. So as you can see here, this is a choline carrier. We know we need an acetyl and we need a choline. They formed, two of them form one, which is acetylcholine. So it inhibits the uptake of choline, okay? And you can kind of remember it as in choline is half of acetylcholine. Half means hemi. Hemicolinium is going to inhibit half of the acetylcholine to go back, okay? So it inhibits the precursor, which is choline, hemicolinium. Then we have inhibition in the storage of acetylcholine, and acetylcholine is going to be stored in vesicles, right? So what sounds like vesicles? Vesamicol. So vesamicol is going to inhibit the storage of acetylcholine in the vesicles, okay? So that's another way to remember it. Another thing is botulin, which I know all of you all know right now. The botulinum toxin is going to inhibit the release of acetylcholine from the synapse, okay? And then we have physostigmine, eustigmine, and we're going to mention them right now, okay? So basically, for cholinergic agonists, we have two types, direct acting and indirect acting. So direct means that it looks like acetylcholine and it binds to the receptor of acetylcholine. Indirect means that it's not going to bind to the acetylcholine, but through another method, which is inhibiting this enzyme, acetylcholine esterase. It's going to keep acetylcholine in the synaptic membrane for as long as possible, and therefore its agonistic effect, okay? And these are all the drugs that you should know. I think it'll be easier to just do this. These are the drugs that you should not know, okay? So these are all drugs that are going to be mentioned. Okay, so when you give a cholinergic agonist, it's obviously going to have adverse effects, which are similar to what would be if you stimulate the cholinergic system too much, okay? So that includes diarrhea and diaphoresis. Why diaphoresis when it's sympathetic and not parasympathetic? How would this be a side effect? Why is sweating a side effect of a cholinergic agonist when it's a sympathetic function rather than a parasympathetic function? Yes. So sweat glands, we said that they are stimulated by acetylcholine. So although it's sympathetic, but here you're giving the acetylcholine or cholinergic agonist, so it's going to have an effect on the sweat, okay? And meiosis, pupil constriction, nausea, vomiting, and urinary urgency, because again, it's going to do that. And then decreased blood pressure and bronchospasm. So if someone has asthma and they take a cholinergic agonist, they might not be able to breathe at all, okay? Because it's going to increase the secretions and constrict the bronchioles, okay? So here we have our first type, which is the direct agonist. So the first one is bethanicol. If you realize, almost all of them call for choline because they look like acetylcholine, except this one. So bethanicol, basically, it acts on the bladder, okay? It acts on the bladder. It's going to cause constriction, and it's also only muscarinic, not really nicotinic receptors, mainly muscarinic receptors, and almost all of them are like that. And this is not a nice mnemonic. I saw another one. It kind of said that Beth pisses me off. So basically, bethanicol is going to cause you to pass urine, and therefore it's used in urinary retention. So the drug of choice in urinary retention is bethanicol, okay? And it's resistant to acetylcholine esterase. This one, they're all resistant to acetylcholine esterase, okay? Then we have carbachol. Carbachol is basically used in glaucoma, open angle glaucoma. So only when it's mild, not a very emergency glaucoma situation, but yeah. And since it's used topically in the eyes, it has very limited side effects because it's just in the eye, okay? Again, it's resistant to acetylcholine esterase. And when we say it's resistant to acetylcholine esterase, there are still other choline esterases that can break them in the body, but specifically not acetylcholine esterase, okay? So bethanicol for urinary retention, carbachol for glaucoma, okay, never mind. Methacholine is basically a drug that has a very, very short half-life, okay? And since it has a very short half-life, it's only used as a challenge test for diagnosing asthma. Basically, if you give it to someone and they have asthma and bronchoconstriction happens, they're not going to be able to breathe. And now you'll know that, okay, this patient might actually have asthma. So yeah, and to kind of remember this, meth is challenging to quit. So yeah, it's used for the challenge test of asthma, okay? Then we have pilocarpine. Pilocarpine, sorry, 1 second. Again, it's used for emergency closed angle, narrow angle glaucoma. So someone who basically it's a very severe emergency because you can go blind. So then they use pilocarpine with other drugs, okay? So it's the drug of choice in that situation. And also when you have dry mouth, dry eyes, and so on, it's going to increase the secretions because that's the function of parasympathetic. So it's used in situations like Sjogren, because then those are the people who have xerostomia, which is dry mouth and dry eyes and so on. And very nice about it is that it can cross the blood-brain barrier. So yeah, it crosses the blood-brain barrier, again resistant to acetylcholine esterase, and it's the drug of choice in emergency glaucoma and Sjogren syndrome, xerostomia, and dry eyes, and so on. Here it says you cry, you drool, and you sweat on your pillow. So it's does all of these. It's used for the saliva, the eyes, lacrimation, and so on. Okay. Then we have the indirect, which is they're reversible or irreversible. Reversible is like donepezil, rivastigmine, galantamine. Okay. Donepezil, Riva, and Gala, kind of count them as one drug. They're all used for the same thing, which is Alzheimer's disease. And here there's like a little mnemonic that says Donna Riva forgot to dance at the gala because they forgot. So Alzheimer, Donepezil, Riva, rivastigmine, Gala, galantamine. All of them are the first drug of choice to use in Alzheimer's, okay? Then we have edrophonium. Edrophonium, much as methacholine, has a very short half-life, and therefore it's used to diagnose myasthenia gravis. Methacholine for asthma, edrophonium for myasthenia gravis, okay? Then we have neostigmine. Neo is basically used for myasthenia gravis to treat myasthenia gravis, edrophonium for diagnosis, neo for treatment of myasthenia. And also, very importantly, it's used as an antidote to revert the neuromuscular blocking by an agent called tuberculin, which is an antagonist. So tuberculin is used to block the muscles during surgery. After that, you give neostigmine to reverse that action. And lastly, we have physostigmine or physostigmine. This is annoying. Okay. Physostigmine, basically, this is the one that's used when you have, for example, you have anticholinergic crisis. Basically, you were given a lot of anticholinergic drugs or something. So then you're going to use physostigmine to revert that action. So if someone had a toxicity from atropine, you use physostigmine, okay? So physostigmine fixes, or physostigmine fixes atropine dose, okay? And neostigmine does not cross the blood-brain barrier, but physostigmine crosses the blood-brain barrier, freely crosses the blood-brain barrier, okay? And side effects include convulsions, bradycardia, and also it's going to, it might go to the neuromuscular junction and lead to paralysis, but that is only if it was toxicity. At normal doses, it should not cause the paralysis, okay? And then the last ones, the irreversible. Irreversible, we have two. Organophosphates, which is the nerve gas, sarin, incesticide, they all have organophosphate. This is irreversible, binding to acetylcholine esterase, causing respiratory depression and can lead to death. And then we have ecothiopate, which is not really used, honestly. In glaucoma, not first line. I don't think it's a very important drug, ecothiopate, okay? It's just an echo. It's not the real thing. And never mind. Okay. So basically, toxicity caused by specifically organophosphate, because it's irreversible. You can remember it as dumbbells, diarrhea, urination, meiosis, bronchospasm, bradycardia, emesis, lacrimation, salivation, and sweating, okay? So these things is a cholinergic crisis. And basically, what drug can you use to reverse this? First, we have pralidoxime. Pralidoxime basically is going to reactivate the inhibited acetylcholine esterase, but that's only if it's given within like the first 4 hours. And then we have atropine, which is going to be a competitive inhibitor. So it can be used, but pralidoxime is used in the earlier hours. And the last drug, nicotine. Nicotine is going to work on the nicotinic receptor, and it's used for smoking cessation because smoking, they're addicted to the nicotine. So I don't know how that works, but they're going to give nicotine to help quit smoking. And then another drug also is called varenicline to decline the use of smoking, right? Okay. So yeah, at low doses, nicotine is stimulating. At high doses, it's antagonizing. So it's important to know this. Nicotine at low doses stimulates, at high doses antagonizes, okay? So yeah, do you guys have any questions related to the previous part? I know it was a lot. There are a lot of drugs. Or you can answer this question if you don't have any question. What is the drug of choice in emergency closed angle glaucoma? Okay. Someone said C, someone said E. E. Okay. Why not A? I think I remember saying that A is used for glaucoma. It's not first line slow acting. Yeah, so basically, in emergency, it's pilocarpine. Yes. However, in normal open angle too, it's carbachol. Okay. Physostigmine, it's the drug of choice in fixes something. Physostigmine fixes what? Atropine, yes, atropine overdose. Atropine is anticholinergic and is in fact contraindicated in people who have glaucoma because it's going to worsen it and might cause blindness. Beta-lactams is the drug of choice in, yes, tetracycline antidepressants too because they also cause anticholinergic effects. Beta-lactam, urinary retention. Pilocarpine is the drug of choice in other than emergency glaucoma. Cry, sweat, and drool, or cry, drool, and sweat. I can't remember anymore. Xerostomia, yeah, and Sjogren in general because dry eyes, dry mouth, it increases secretions. Okay. So yeah, pilocarpine is the answer. Another question: which of the following drugs is an irreversible, indirect acting cholinomimetic? Okay. Someone said A. Someone said E. Okay, another person. Okay. So the answer is E. Neostigmine, physostigmine, donepezil, galantamine, rivastigmine. They're all reversible, indirect acting. Ecothiopate and nerve gas or statin or organophosphates. These are the ones that are irreversible, indirect acting. Neostigmine for myasthenia gravis, donepezil, gala, riva, all for Alzheimer's, and ecothiopate for glaucoma, not first line. Honestly, I don't think it's a very important drug. Okay. So yeah, I think this is Momo's part.
Oh yeah, okay. So I think we're still continuing like on the autonomic nervous system part. So which of the following is a systemic effect of a muscarinic agonist? So I know she explained, like Shamiaa explained a lot, like in a few slides. And she did a very good job because I wanted to explain the same, same way. But yeah. Okay, so what's a muscarinic agonist? Someone said A. Okay. So that's good. So the answer is A. This is a very like direct question, without like naming any drugs. Examples are all the drugs that she gave above, and muscarinic, cholinergic. I like to think of them as the same thing, and which means parasympathetic, right? So the only option here that's like that is like parasympathetic action is reduced heart rate, bradycardia. Increased blood pressure is a cause of sympathetic, like is an effect of sympathetic action. Dilation, remember the eye has to be bigger for more light, sympathetic. Reduced urinary frequency, again, same thing, sympathetic. And constipation. So these are not, like all of them are sympathetic. The only one that's parasympathetic is A. Okay, does that make sense? Is it clear? Okay, I hope so. Okay. It's fine. Yeah, we can move. So during an ophthalmic surgical procedure, the surgeon wanted to constrict the pupil of the patient using a myotic drug. However, he accidentally used another drug that caused dilation of the pupil, sometimes called mydriasis, instead. Most likely, which of the following drugs did he use? So again, same thing, but yeah. So now in this case, what class of drug do you want to use? Or like what class of drug is being used for pupil dilation? Like can you tell me like agonist, antagonist, or is it adrenergic or cholinergic? I think there are two answers for this, but okay, go ahead, yeah. Antagonist, good. What antagonist? If it's antagonist, which class? Cholinergic antagonist, good. Or muscarinic antagonist, good job. So which of the following here is an cholinergic or muscarinic antagonist, which causes pupil dilation, right? Because it inhibits parasympathetic, more sympathetic kind of like acts, and it causes dilation. Okay, so someone said C. We can, okay, C. Okay. So good, yeah, the answer is C, tropicamide. Tropicamide is an cholinergic antagonist, like we said. The rest, acetylcholine, for example, that's agonist, right? Pilocarpine, phentolamine, bethanechol, remember the one that was in the table? These are all like they won't cause pupil dilation. Wait, if you go to the next slide. Oh wait, after this question, there's one more, and then I'll explain both of them together. So which of the following drugs from this list would be the most effective anti-motion sickness drug for a person planning to go on a cruise? Okay, good. I'm really happy. So C, scopolamine is again used, like one of the uses of scopolamine is in motion sickness. So like definitely remember that for for the exam. Wait, if you go to the next slide, there's this slide. Yeah, okay. So this slide is from your lecture, the same thing, cholinergic or muscarinic antagonist, right? These are like three different drugs. Just know them because they're in green, and I think they're very important. So scopolamine, like we mentioned, important for motion sickness, right? And like it inhibits the vomit, like your like antiemetic, so inhibits vomiting reflex, but it causes sedation. Also from S and S, it causes sedation, but it's helpful for when you have motion sickness. Ipratropium is another one of this class, as well as tropicamide. Tropicamide, I want to focus on this more because it's used to dilate like the pupils if used as a drug, right? It can. And over a short period of time, and you all got that right. Okay, so do you okay, so let's move on to the next one. We'll take a break after this part, after we finish for this part for autonomic, because I know we said a lot. So which of the following is correct regarding the neuromuscular blockers? So now we're moving on to neuromuscular blockers. So which one of the following is correct? Okay, someone said B. What do you guys, okay, B. So what's a neuromuscular blocker? Like what do you get when I say that? It's just from the name itself. So it blocks. Okay, so it blocks good. Muscarinic receptor blocks a acetylcholine binding. Good, so that's what it means. So now if okay, we can show the answer and I'll explain why that is and why the others are wrong. So good for everyone who said B, because when you give someone cholinesterase inhibitor, wait, muscarinic. Oh, sorry, nicotinic. My bad. It's a nicotinic blocker. I'm sorry. Thank you, Shamiaa. Okay, so now because you're using cholinesterase, if you're using cholinesterase inhibitor, right? Cholinesterase is the enzyme that breaks down the like ACH or acetylcholine at the nicotinic receptors. Sorry. Now, because if you're using cholinesterase inhibitors, if you're inhibiting the enzyme that breaks down the acetylcholine, which is the neurotransmitter, it reduces the effect of non-depolarizing neuromuscular blockers. I know it's like the opposite effect. It's kind of what do I call it? It's the opposite, right? Because you're using non-depolarizing neuromuscular blockers. You can forget about non-depolarizing or depolarizing. You're basically blocking the neuromuscular junction, right? Now, if you're using another drug that inhibits the enzyme that breaks down the neurotransmitter itself, the neurotransmitters will increase in the synapse, right? Which will reduce the effect of neuromuscular blockers. Does that make sense? I'm sorry if I know it's a lot. Like I wish there was a picture to explain this. But is this clear? Do you have any does anyone have any questions? Okay, clear, good. So that's what I mean. So it's like two drugs are acting at the same time. So one of them reduces the effect of other because it blocks the inhibitor. Okay. Others are yeah. Neuromuscular blockers are usually they're not usually administered orally, they're parenterally, which means like through IV injections and so on. Non-depolarizing affect diaphragm muscles first, not necessarily. And effects of depolarizing neuromuscular blockers can be reversed using, no, so that's the complete opposite option, right? So I'm glad you guys got like why this happens. Okay. Do you want to move to the next part? Okay. I think we're almost done with this part. So a patient was administered again a neuromuscular blocker prior to surgical procedure to produce skeletal muscle paralysis. This neuromuscular blocker caused initial skeletal muscle fasciculations before the onset of paralysis. The effect of this drug could not be reversed with neostigmine. Which of the following neuromuscular blockers was most likely administered to this patient? Okay, so B. I got this question because it's like the most, in my opinion, it's one of the most important drugs in neuromuscular blockers, right? So does anyone have other answers for this? If there's something you didn't take, like cross it out. C. Okay, what's C? Like what class of drug is C under? I'm just asking just to explain the answer better. Someone said D. Okay. Okay. So central C. Okay, yeah, it does act on the central nervous system. Diazepam. So diazepam is a class of if I'm not wrong, it's a class under benzodiazepines, right? Lorazepam, diazepam, all those are under, it acts on GABA receptors. I don't know if you took it in POD, let me know if you did. Like I don't want to explain too much because that's in neuro. Okay, basically, oh yeah, you didn't, then yeah, cross it out. Diazepam, if you didn't take it, then yeah. because it's for benzodiazepines, which is another class of drug. So neuromuscular, it's okay if you, oh, you took it? Okay, if we mentioned it briefly, it's fine. It's good to know, but again, like I said, it's a it's a benzodiazepines class, right? Now we're talking about in this question, it's like it's okay if you said like other answers because this way you're learning, right? Neuromuscular blockers, A, B, and C, A, B, and D, they are like part of, if I'm not wrong, neuromuscular blockers, but there's one of them there's two types, right? Depolarizing and non-depolarizing neuromuscular blocker. Now, which one of them is a depolarizing blocker? Which means like you're depolarizing the right? Okay, B, good. B is. Now, that means from the name, it depolarizes. For a short while, it does. For a short while, it depolarizes the muscle, right? That's why you see muscle fasciculations. It's the only neuromuscular blocker, like depolarizing neuromuscular blockers are the only neuromuscular blockers where you see like muscle fasciculations, which means muscle contractions for a bit, for a short while, and then it goes into paralysis because you're opening the channels too much and it's being depolarized too much, right? So there's sensitization of the receptors. Now, that's why B is the right answer here. Cisatracurium, everything with the ending like curium, are even verocunium are non-depolarizing neuromuscular blockers. So that means they don't present with fasciculations. If you go to the next slide, I think I got a picture from, yeah, so here. So this is a result of using succinylcholine, which is a depolarizing neuromuscular blocker. You have two phases. In phase 1, you have fasciculations or contractions for a while. And then phase 2, because it's being stimulated too much, that's why you have paralysis, okay? You can see here, like the receptor is desensitized to the effect of acetylcholine. Does that make sense now? Like clear? Okay, that's good. Let me see. Wait, Shamiaa, do you want to stop here, or I think there's more, but I feel like if we talked so much. Don't show them the slides. Okay, anyway, yeah. It's fine. Do you want to continue now or like take a break like everyone else here? We can take a break for like prayer and then okay. I think it's better if we take a break now. Okay, yeah. I think let's join in 10 minutes maybe. 10 minutes good enough? Because we're almost done. We're almost done. I know we had a lot of slides, but also some of them were like for explaining. That's why. Okay, yeah. Let's come back at 5:20, okay?
Sure. Come back at 5:20 then.
Yeah, thank you. Okay, so wait just a second. Okay. So remember how, yeah, so we stopped in this question, right? And I was trying to explain neuromuscular blockers. So there's two types, depolarizing, non-depolarizing. Just remember that A and D here are considered non-depolarizing drug, which means that they competitively like bind and block. Basically, they don't even depolarize, they just block the receptor and to block the neuromuscular junction from working, right? Succinylcholine is not depolarizing, which means it depolarizes, and then this is what causes the fasciculations you see in this question, okay? Is that clear? I think Shamiaa wanted to ask a question, wait, for this, because
Yeah.
I think she explained, yeah, go ahead.
Sorry, what? Okay, guys, which drug can be used given as to reverse the neuromuscular blockage of tuberculine? Okay, yeah, neostigmine.
Okay. Yeah, so that's good. So do you see here, for example, succinylcholine cannot be reversed with neostigmine, but the other like non-depolarizing neuromuscular blockers can be reversed. Okay, I'll move on if that's clear. If this is all clear, I'll move on. Okay. Which of the following is correct regarding adrenergic neurotransmission? Now we're moving to adrenergic, right? So which one of them is correct? So we talked about, okay, yes, someone said C. We talked about cholinergic antagonist agonist. Now we're going to adrenergic or related to sympathetic nervous. Does anyone have other answers, like other than C? It's okay. We'll show the answer and then I'll explain why. So first let's see why it's not the rest. Epinephrine is the major neurotransmitter released from sympathetic terminals. Usually norepinephrine is more like most of the neurotransmitters from sympathetic, even though, yeah, this is correct, like adrenergic is sympathetic, right? Norepinephrine is mainly released from adrenal glands, not only from adrenal glands, right? It's from, like, it's part of the sympathetic neurotransmission, but yeah, but from adrenal glands, mostly it's epinephrine, if I'm not wrong. So C, tricyclic antidepressants and cocaine prevent reuptake of norepinephrine into the nerve terminals. C is right, so C is the answer. Just know, so what I wanted you to know from this question was that there are like tricyclic antidepressants and cocaine. So people who are like toxicated, like they are intoxicated with cocaine, the effects of them are because they prevent reuptake of the neurotransmitters in adrenergic, which is mainly norepinephrine. Monoamine oxidase converts dopamine to norepinephrine. No, it does not. So monoamine oxidase is what breaks down the neurotransmitters, right? It doesn't like produce more norepinephrine. So I don't know why this is not clear, but this is from the lecture. I think Dr. Manal gave it to you. But basically, you can see here, cocaine inhibits or blocks the transport back into the recycling of the neurotransmitters from these, and it does so for all three of the neurotransmitters: norepinephrine, dopamine, and serotonin. Okay, now this question was mainly for norepinephrine. You can see it here, like it's blocking, so it has a similar, not similar shape, but it has the ability to bind to reuptake molecules like these that usually take up norepinephrine. Okay, is that clear for everyone? Okay, good. So it's good you got that. Next question. Okay. Yeah, a 23-year-old man presents to the pharmacy with complaints of a bad cold. He asks for medication that will offer temporary relief of nasal congestion. The pharmacist recommends phenylephrine nasal spray. What is the mechanism of action for this medication? Okay, someone said B. Good. So B is the right answer. Main like takeaway from this question again is like phenylephrine in the use and its use as nasal congestion, right? So congestion, like bad cold, all of this happens because of vasodilation of the blood vessels, right? It would make it better if you vasoconstrict them so that there's less congestion. So you can do that by again, so remember the mnemonic that Shamiaa gave a while back? It was A, for alpha is for constrict A1C, that one. It's a very good mnemonic. So the answer is B. You stimulate alpha adrenoreceptors for vasoconstriction. So that makes sense. A, they're saying block beta adrenoreceptors for vasodilation. Beta receptors do like cause vasodilation, but for nasal congestion, we used phenylephrine, which is an alpha agonist, alpha adrenoreceptor agonist. Okay. So usually one of the side effects of this medication is that it can cause rebound congestion. Like if you use it for a long time, it can result again in congestion, but that's just another thing. Is this clear for everyone? So muscarinic, these are not related. Like you want adrenergic agonist. Okay. Should I move on from this question if it's okay? Okay, good. Okay, this is another easy question, but just so you know the anatomy, like what Shamiaa with the picture, so I showed you with the picture. So assuming the structure is part of the thoracolumbar system, norepinephrine acts at which one of the following sites in the diagram? Okay, someone said C. Again, it's like a recall question, but it's very important you know where these like agonists, antagonists act and where norepinephrine is released and so on. So the answer is C. Wait just a second. Yeah, C, which is sites 5 and 6, right? So when I say thoracolumbar, what does that mean? Like, is it sympathetic or parasympathetic based on location and based on the table? Good. So sympathetic. So sympathetic, again, norepinephrine is the major neurotransmitter, and it acts at the post ganglionic neuron, like at the end between the junction of the last neuron, the post ganglionic, with the effector cell. Okay. Here I'll show you a diagram, which is the same exact one that was showed before too, but in a different way. For example, like this is just to make it more clear. You have nicotinic receptors for somatic, and then here between like preganglionic for sympathetic, preganglionic for parasympathetic, and adrenal medulla. Again, do you see here, for example, sympathetic, main neurotransmitter, again, norepinephrine. For adrenal medulla, main neurotransmitter is epinephrine. So just know that they're kind of like the opposite ones, right? Sympathetic, you have, again, adrenergic receptors. We talked about it like a lot, alpha 1, alpha 2, beta 1, beta 2. And again, sweat glands is also by acetylcholine, if you guys remember that. And the major neurotransmitter everywhere else is acetylcholine. Okay, so this is the distribution in autonomic nervous system. Now, again, another one, a 70-year-old patient was brought to the emergency room with a blood pressure of 76/60, which is low, tachycardia and low cardiac output. He was diagnosed with acute heart failure. Which of the following drugs would be most appropriate to improve his cardiac function? C. Okay, good. But can someone tell me why C? Why not like any A or B or beta 1 agonist? Okay. Okay, so I think, yeah, most of you said C, so the answer is C. Good. Dopamine is usually because it's a beta 1 agonist. Remember, beta 1 acts on the heart. There's another way I like to remember it. You have one heart, right? So beta 1. You have two lungs, so that's beta 2. Beta 2 dilates in the lungs. Beta 1 constricts or increases sympathetic in the heart. So dopamine is one of them. Phenyldopam does the complete opposite, and I don't think you took it in POD yet too, but it's for malignant hypertension, which means like the blood pressure would be like 200. It's a very high number, then you would use phenyldopam, but you don't need to know, it's just extra. Again, isoproterenol is beta 1 and beta 2. So not really. This is just you want to increase the cardiac output because that's the main complaint here. And epinephrine is a neurotransmitter, but again, the main for neurotransmitter for sympathetic is norepinephrine. Okay. Okay, if that's clear, we can move on. I think this is Shamiaa's.
Yes.
Okay, go ahead. Yeah.
Okay. So a 70-year-old male needs to be treated with an alpha blocker for overflow incontinence due to his enlarged prostate. Which of the following drugs would you suggest in this patient that will not affect his blood pressure significantly? D. Okay. Any other answers? Or the same answer? D again. Okay, why D and why not the other drugs? If you chose to choose D. D has most receptors in the prostate. Okay. D doesn't cause hypotension. Okay, yeah. Yeah, so the most accurate one would be because there's alpha 1A receptors that are specific for the prostate, and tamsulosin is very, very specific to these receptors more than the other alpha 1 receptors. That's why it's the best drug of choice for BPH, okay? And we're going to see the others right now. So, sorry, can you move to the next slide? Yeah, so tamsulosin is the correct one. So basically, to know about adrenergic antagonists, we have alpha blockers and beta blockers because these are the receptors, right? So alpha blockers can either be reversible or irreversible, okay? And therefore, the duration of action of the drug would depend on, if it's a reversible blocker, then it would depend on the half-life of the drug, right? The duration of action. However, if it's an irreversible drug, it's going to be bound permanently to the receptor. So the duration of action would depend on how fast new receptors are going to be synthesized, okay? So it's important to know that because it was underlined in Dr. Manal's lectures. If it's underlined in her lectures, it's important to know, okay? And if it's green in Dr. Dana's lectures, it's important to know. So as for the beta blockers, most of them are reversible, okay? And also most of them don't have much of a selectivity. Yes, they say that this is a selective beta antagonist or blocker. However, if you increase the dose, it's going to start affecting beta 2, for example. If you're putting selective beta 1 and you increase the dose, it's going to affect beta 2, okay? And something specific to beta blockers is that they have, some of their drugs have these characteristics. One of them, which is partial agonist. Partial agonist, from its name, it's half an agonist, okay? So what does that mean? It means that if, for example, you put the normal signal, for example, which is epinephrine, it's going to produce a certain effect on the beta receptor, causing all these effects that it should do. However, if you put an antagonist, it's going to block these effects totally, right? So epinephrine is going to give you the full effect. Antagonist is going to give you basically no effect. And then partial agonist is going to give you a slight effect. So it's more than that of an antagonist, or more than that of when the receptor has nothing bound, but it's less than that when there's an more agonist or an epinephrine. So basically, if you wanna, when do you use partial agonist? A partial agonist in the presence of an endogenous signal or a high endogenous signal. If you have high amounts of epinephrine in the blood, for example, and you give a partial agonist, this is going to improve your symptoms because the partial agonists are going to compete with the endogenous signal that's there, and it's going to decrease the effect because its effect is less than that of the complete agonist. However, if there's no signal and you give the partial agonist, it's going to produce more effect. I don't know if you got that. It's kind of confusing, but yeah. Inverse agonist, from the name, it's inverse. So an antagonist produces no effects. An inverse agonist is going to produce opposite effects of that of what is normal of the receptor. So for example, say that beta receptors are going to cause bronchodilation, And if you put an antagonist, nothing's going to happen. If you put an agonist, then this is going to cause the opposite effect, which is, for example, bronchoconstriction. Okay. Then this one, which is not very important, the local anesthetic action or membrane stabilizing action. Basically, it blocks sodium channels, so the membrane stays relatively stable. It doesn't get depolarized. And this is important in glaucoma, nothing otherwise, okay? So do you guys have any questions related to the partial agonist, inverse agonist, local anesthetic? Or we can move on. Okay. So basically, this diagram from the slides also shows a full agonist gives you the full maximum response. A partial agonist give you that of less than an agonist. So if you got a partial agonist and you had it compete with a full agonist and you put more of it, then you're kind of antagonizing the effect of the full agonist, right? Then we have antagonist, which gives basically just the normal activity, like nothing. And then inverse agonist, which is going to give you the opposite effects. Okay, so yeah, we can move on, I think. So yeah, back. One back. Okay. No, wait, before. Oh yeah, okay, sorry. Yeah. So yeah. So basically right now, first we have the not selective or non-selective alpha receptors. First we have phentolamine, okay? Phentolamine it's basically non-selective. Alpha 1 is alpha 2 the same, but it has a very, very short half-life. And since it has a very short half-life, it's used in, for example, you have a hypertensive crisis due to pheochromocytoma or something, but very short-term management. You can give them phentolamine, very short acting, but it's going to reduce the blood pressure because alpha 1 causes vasoconstriction. You block now, there is vasodilation, okay? But it's very, very important to know that because alpha 1 is going to cause this vasodilation and sudden decrease in the blood pressure, this is going to cause reflex tachycardia, and the heart is going to increase the heart rate basically as a response, as a compensation to the decreased blood pressure. And therefore, one of the adverse effects of phentolamine specifically is significant cardiac stimulation, okay? So significant cardiac stimulation because it's going to cause reflex tachycardia. The other drug, which is phenoxybenzamine, just like phentolamine, however, it has a much higher half-life, and therefore it's used for the long-term management of pheochromocytoma in cases where you cannot remove the adrenal gland or something, or pre-operative. So before they do the surgery of pheochromocytoma, they're gonna give phenoxybenzamine to basically reduce the blood pressure so that the person is stable so that you can do the surgery, right? And always remember, you block alpha before you block beta, because if you block beta first, what's gonna happen? You're gonna have the opposite, which is a hypertensive crisis, because instead of reflex tachycardia, you're gonna get reflex vasoconstriction, and that's gonna worsen everything. So A before B, block alpha before beta, okay? And you're gonna use phenoxybenzamine in cases of preoperative pheochromocytoma. And as you can see, that phenoxybenzamine binds irreversibly. That's why it has a very, very long duration of action, and because it binds covalently with the receptors. Covalent bonds are very strong bonds. And basically, side effects include orthostatic hypotension, which is very important, orthostatic hypotension. And since it can cross the blood-brain barrier, it's going to cause sedation, fatigue, and nausea. So orthostatic hypotension and crossing blood-brain barrier. For phentolamine, it's cardiac stimulation. And yeah, so Lean's saying there's a trick. The drug has 16 letters and pheochromocytoma has 16 letters. To remember which one treats it. Okay, so I guess phenoxybenzamine, since it has longer letters, it can be used to treat pheochromocytoma. Both of them are the same amount of letters. Yeah. Okay, last slide. Thank you. So the next slide. Then we have the more selective, which all end in osine. They're more selective for alpha 1. Prazosin, terazosin, doxazine have selectivity for alpha-1 more than alpha-2, and they're used for hypertension. Obviously, all of these are not really first line. Hypertension, Raynaud's, which is basically when there's vasospasm of the peripheries and the fingers turn blue and there's less blood there. So you want to vasodilate. And benign prostatic hyperplasia. However, since they are only selective for alpha-1 and not alpha-1A, if you give it to someone with benign prostatic hypertension who hyperplasia who does not have hypertension, it's gonna cause them hypotension. So prazosin, for example, you can use in a person who has both BPH and hypertension. Okay, but if it doesn't have hypertension, then tamsulosin is the best drug because it has a selective it's selective for alpha-1A. Okay, so since it's selective for alpha-1A, which is mainly present in the prostate, then you're going to use tamsulosin for benign prostatic hyperplasia. Okay, and it has a side effect which is called intraoperative floppy iris syndrome, specific for tamsulosin. Intraoperative floppy iris syndrome. Okay. So yeah, next page. Now for beta blockers, I found that from the slides it was a bit messy, so I got it from first aid. But here you're going to have the application and how it works on it and the examples. So for angina and myocardial infarction, why do you use beta blockers? Because they're going to reduce the cardiac output, reduce the heart rate, and therefore they're going to decrease the oxygen demand of the heart, and it's going to improve the overall situation. So you can use beta blockers for this situation. Okay. For glaucoma, there are beta-1 receptors in the eye that produce aqueous humor, so decrease production of aqueous humor, and specifically for glaucoma, the drug is timolol. If you guys remember, for the cholinergic antagonist, the drug was tropicamide to cause opening of the eye. Here it's timolol, TT. I don't know if that's going to help you remember, but both of the drugs for the eye, they use the letter T, so timolol. Then hypertension, obviously, because it's going alpha-1 constricts, you're going to block that, then it's going to cause hypotension. And also, it's going to reduce renin secretion from the kidney. So both ways, you're going to, beta blockers, never mind. Beta are going to decrease cardiac output, not alpha. Beta is going to reduce cardiac output and decrease renin secretion, and therefore decreasing the blood pressure. Another thing is hyperthyroidism. Hyperthyroidism causes symptoms like tachycardia and so on, and therefore you can use beta blockers to block the tachycardia and decrease it, and specifically propranolol. And propranolol is non-specific, beta-1 and beta-2, okay? Then we have, I'm going to go into the specific and non-specific in a while. For not hypertrophic, you don't have to know that, but myocardial infarction we mentioned, and SVTs or arrhythmias in general, the beta blockers are going to block the AV node, and therefore if you have an arrhythmia, it's going to improve that arrhythmia, and you can use metoprolol or atenolol. So timolol, propranolol, timolol for the eyes, propranolol for the hyperthyroidism, and metoprolol for the AV conduction. Okay, next slide for selectivity. So basically, this is an easy way to remember what is selective and what is not. Always know that selectivity is to beta-1, okay? And non-selectivity is when 2 is added, so a second thing is added, okay? So to know if a drug, if this beta blocker is selective to beta-1, it starts with letters with the first half of the alphabet, letters from A to M. So atenolol and metoprolol are selective to beta-1, which is the first half of the alphabet, okay? Any drug. Non-selective, they're from N to Z, okay? So from N to Z, like propranolol, timolol, the letters are between the alphabets of N to Z, then they're going to be non-selective anymore, and you added the second half of the alphabet, basically, okay? Beta-1 and beta-2. And then basically we have ones that are bind to both alpha and beta, okay? And these are carvedilol and labetalol, okay? So that means that carvedilol, labetalol block both alpha receptors and beta receptors, okay? And how do you remember this? Instead of them having olol, they will be something else. Like carvedilol is ilol and labetalol is alol. It's not olol. So selective is first half of the alphabets, non-selective second half, and alpha and beta, it's not olol, it's something else. Okay. So we can move on to the question if you guys have any. Yeah, okay. So the adverse effects, obviously, of beta blockers in general, they're gonna cause bradycardia because they're gonna stop the heart, cold extremities, not enough blood is reaching. They can mess up with the lipid profile. If you guys remember that beta-3 is present in the adipose tissue, so it can also affect that. Worsening of asthma and COPD. Why? Because beta-2 causes beta-2 agonist is going to cause bronchodilation, sympathetic. If you're going to block that, you're going to cause bronchoconstriction, and therefore you should not give it to people who have asthma. Okay? And hypoglycemia, some of the signs of hypoglycemia is tachycardia and nervousness and so on. If you give beta blockers, that's going to mask the effect of hypoglycemia. And that's why it's very dangerous. So someone can have hypoglycemia, but you give beta blockers and you will not notice, and it's going to worsen it, and the person might go into a coma eventually. And yeah, basically that's it. So do you guys have any questions? Or you can answer this question. So a new antihypertensive drug was tested in an animal model of hypertension. The drug, when given alone, reduces blood pressure in the animal. Norepinephrine, when given in the presence of this drug, did not cause any significant change in blood pressure or heart rate in the animal. The new drug is like which of the following drugs in terms of its pharmacological mechanism of action? So which one? Oh, there's a question.
Yeah, there was a question just now.
Yeah. What's floppy iris syndrome? Well, I'm gonna search right now. It's loss of muscle tone in the iris with pupil constriction, despite you giving dilation. Something weird, but it was written in the question. But basically, there's loss of tone in the iris muscles. Yeah, no problem. Okay. So what do you guys think the answer to this question is? Okay, I think it's a bit difficult, but basically, this animal was given a drug that reduced hypertension, okay? Reduces the blood pressure, right? And then when you gave norepinephrine, what does norepinephrine normally do? Norepinephrine, what does it do to the blood pressure? It increases blood pressure. However, when you gave norepinephrine in this patient, nothing happened, neither to the blood pressure nor to the heart rate. Norepinephrine usually reduces blood pressure and what to the heart rate? Reflex. Norepinephrine causes brady. Norepinephrine, when given, yeah, it causes reflex tachycardia. Why? Because norepinephrine has a very strong affinity to alpha-1. When it blocks alpha-1 and causes vasoconstriction, like we said, for example, phentolamine, it's gonna cause reflex tachycardia. Okay, so in this patient, even though you gave him an agent, and now you gave him norepinephrine, which is a drug that's gonna significantly affect the blood pressure, but also it can also cause yeah, it's gonna cause tachy too. So yeah, does not. I was wrong about the reflex tachycardia. Reflex tachycardia is if you block the alpha. Norepinephrine stimulates the alpha, so it's gonna cause reflex brady, but then it's gonna cause tachy in the eventually because it will bind to the beta receptors, but it's more selective to alpha. So yeah. So basically, the question is asking which this drug blocks both alpha and beta, and therefore when you gave norepinephrine, nothing happened because it blocked both alpha and beta. So what's the answer? E, two E's and one C. Okay. So prazosin, what does it block? Alpha 1, okay. And okay. I don't know about clonidine, propranolol, what does it block? Beta 1 and beta 2. Metoprolol.
Clonidine, I think clonidine is alpha 2, but I think if you didn't take it, it's fine. If it wasn't, yeah.
Was it in the lecture? Yeah. Thank you. Metoprolol, what does it block? Beta 1 and some 2, yeah, it's kind of selective. Carvedilol. Beta and alpha, yeah. So the answer will be E, okay? Because carvedilol and the other drug, which is labetalol, if that was an option, that would also be correct because it's gonna block both. Prazosin is only alpha, so if you gave norepinephrine, the heart rate might have increased because it binds to beta, okay? So yeah. Okay. Please. I'm done. Do you guys have any questions related to adrenergic blockers?
Autonomic, yeah. I think
Or autonomic or yeah, antibiotic?
antibiotic. Okay, wait, someone's answering. Okay. I think there's no questions, but a 2-year-old is child is brought to the emergency department in convulsions. According to her mother, she had ingested most of a bottle of sleeping pills and over-the-counter preparation. What did the sleeping pills she ingested probably contain? Someone already said C, which is good, but do you guys have any other answers? Okay, C. Okay, what class of drugs is C? Like we're moving on to a different topic now, but yeah, what is it exactly? Good. First generation antihistamine. So the answer is C, anhydramine. So again, first generation, so antihistamines, there's first generation, second generation. Let me see if I have, yeah, okay, here. So this is from your lecture. There's, just know the ones that he colored, because I think those are the ones that are important. First generation basically has a much higher effect in your CNS. So it crosses the blood-brain barrier, which is why it's able to cause like a sleeping. So they can be used as sleeping pills. This is why it causes like sedation and so on. It's one of the side effects actually. So that's why second generation came, like the pharmacists, like they made a second generation of drugs with no side effect of sedation, right? So you can remember it like that. The first generation one came earlier in the market, and that's why they have this side effect that you don't want, that's like sedation. That's why they had to come up with a second generation drug which doesn't cause that side effect. Okay, so diphenhydramine is one of the first generation. Know that promethazine, cyclizine are also part of it. And second generation, again, he highlighted it because I think this one also causes sedation, but it's part of the second generation. Usually if they ask you, it's going to be this one, diphenhydramine. Cetrizine is the only second generation antihistamine that could cause sedation, but again, I didn't see a lot of questions in it, but it's good to know that. Wait, let's see. I think that's it. Loratadine. Yeah, these are different. So caffeine also, they're not used as sleeping pills, for example. Clomiprazine, no, meperidine. Yeah, these are again benzodiazepine classes. If you didn't take it, it's fine. So the answer is C. So I'll move on to the next question if you guys don't have any more questions. So a patient using NSAIDs for chronic pain develops a bleeding ulcer. What drug is designed to selectively treat ulcers of this type? So, okay. Someone said E, I think, for this question. Yeah, E. Does anyone have other answers? So, NSAIDs, does it make sense that someone using NSAIDs would develop bleeding ulcer? Like, what's the mechanism of action of NSAIDs, if I ask you? Good. So it inhibits the cyclooxygenase enzyme. Good. Yeah. So because it inhibits the cyclooxygenase enzyme, we have COX-1 and COX-2, right? Which I'll come to later. COX-1 is mainly for keeping like GI. So it's usually active, right? Like even without inflammation, infection, or anything. So if you block the COX, yeah, exactly, COX-1, COX-2, you end up with no prostaglandins, because prostaglandins is a result of like the cyclooxygenase enzyme. Okay, there's a slide on that later on, but that's why when you block that enzyme, the GI mucosa, like there's not enough prostaglandins, and that causes bleeding ulcers in your gastric mucosa. So what drug reverses, like what drug treats this one? So you want to give prostaglandin, right? So which one of these is which one of these is a prostaglandin? Someone said D. Is it starting to make more sense now? D. Good. Okay, good. So misoprostol is one of the prostaglandin agonists, which is specifically used for bleeding ulcer caused by NSAIDs, because it reverses it, right? Because NSAIDs block prostaglandin, you want to give prostaglandin to treat the ulcer. Again, bismuth is for H. pylori. I know it's also for ulcers caused by H. pylori, but mainly it's to treat, like it has an effect against the bacteria itself. Muscarinic, I know someone said muscarinist antagonist, but in bleeding ulcers, it doesn't have to do with autonomic nervous system now. We're in, like, do you get why it's D right now? Because we're now doing the prostaglandin pathway, or the synthesis, which is important for bleeding ulcers, and NSAIDs in general. Aluminum hydroxide, again, aluminum hydroxide, if I'm not wrong, it's used for constipation, which is not the case here. Famotidine is, again, it's something you didn't take, so don't worry about it. Is that clear? Okay. I thought there's a slide coming for the COX-1, COX-2, but is this clear, misoprostol? Okay, it's prostaglandin. Okay, good. Now, next, a child suffering from mild to moderate asthma is taking a drug that inhibits pulmonary mast cell degranulation. What drug would be an appropriate choice? Again, this is also recall. It's directly telling you what's the mechanism of action. Good. So it's A. Since like most of you here said A, I'll go with like showing you the answer. The answer is A, cromolyn sodium. Okay, so you can see the mechanism of action from the question, and you can relate it to this drug, right? Or cromolyn sodium, which is what I wanted, like, from this question. Again, here, this is a picture I got, but basically mast cells, they degranulate, which releases histamine, which releases leukotrienes. These are like responses to allergic reactions. So whenever you have dust, pollen, this is affected mast cells. Okay, they release histamine, which causes all the effects of allergic reactions, such as like redness, swelling. It's a different lecture too. But if you block the degranulation, if you block the release of histamine from mast cell, even though mast cell can be activated, histamine is not being released, because cromolyn sodium inhibits this release of histamine. So that's why you're like inhibiting the pathway and to develop this allergic reaction, right? So again, I want to just ask, did you take Montelukast zeoleuton in the lecture? If not, it's okay. Yeah, if not, it's fine. Yeah, just focus on this one, okay? These are basically for leukotrienes, but if it was not given, it's fine. And this has a different sort of action. It doesn't like inhibit the release. Ipratropium, again, we're not in that lecture still. And theophylline is also, if you didn't take it, don't worry about it. If this is the only one that It was given, just worry about this and know its mechanism of action, which is here, okay? Now I'll move on if you guys don't have any questions regarding the last question. So here, aspirin is contraindicated in pregnant women near term because of which of the following? Okay, someone said C. Or D. Okay, wait, yeah, some D. So C, you agree that C, like, yeah, I think I got you. So if you're reading all the choices and if they're all right, and usually if there's an answer that says all of the above is correct or all of the above has like the risks, it's usually the answer. But in this case, I just want to explain why aspirin, for this question, D is the answer because it's true, these choices are true all for aspirin, okay? So what does aspirin do? Can anyone tell me quickly? Inhibits COX, yeah. Okay, so aspirin has a special, like from NSAIDs, it's different. Why? Because it inhibits COX differently. Do you know how, like, what's the difference between this and the NSAIDs or other inhibitors of COX-1, COX-2? So aspirin is also, I'll just say it, but aspirin is irreversibly inhibits COX-1, COX-2, and it's sometimes, that's why it's sometimes used as an antiplatelet because its effect is longer than NSAIDs. That's why it's contraindicated also in pregnant women. Okay, now this is all true. Labor may be delayed and prolonged. Why? Because first it inhibits COX-1, COX-1 and COX-2, right? If it inhibits those enzymes, you have less prostaglandin. Prostaglandin is used for smooth muscle contraction, which induces labor, okay? So does that make sense? Now, if you're inhibiting prostaglandin production, you have labor is delayed. Like the smooth muscle is not contracting yet, and then labor is delayed. There is blood loss during delivery. Blood loss during delivery may be more. Again, same thing. So in pregnancy, like during labor, I mean, labor is initiated by prostaglandin smooth muscle contraction, right? It makes sense. The woman is trying to push the baby out. The smooth muscle constricts because of prostaglandin. Now, once the baby is once labor is done, the smooth muscles constrict again to prevent major blood loss. So to prevent the woman from losing too much blood, it has to keep contracting even though the baby is out, it has to keep contracting to close the blood vessels off so that not a lot of blood is lost after labor. So these two, A and B, is again stimulated by prostaglandin, right? So if you don't have that, these two are affected. C, fetus may suffer from premature closure of ductus arteriosus. That's true because aspirin, again, when it prostaglandin in general, prostaglandin keeps the ductus arteriosus, which is a connection between aorta and pulmonary trunk, if you remember. It keeps it open. If you're inhibiting prostaglandin, if you're inhibiting it by the enzymes like aspirin and so on, the COX-1, COX-2, the ductus arteriosus closes earlier than it's supposed to, okay? Does this make sense? So basically prostaglandin affects all of this and you're blocking that effect. Okay, good. Now let's go to the next one. I mentioned this before, but the cyclooxygenase isoenzyme COX-1 and COX-2 differ from each other in that, what's different between them? I remember this because when Dr. Dilip was explaining this to us, he said this exact sentence, in the lecture. That's why. Okay, someone said D. Yeah, someone said D. Do you have any other answers? Does anyone have other answers? Okay, I'll move on. But I just hope this is clear. So if you read the options, right, they catalyze different pathways in prostaglandin biosynthesis. No, right? Because they all end up in the same pathway, which is producing prostaglandins, COX-1, COX-2. The only difference is that, yeah, which is the answer, but I'll come to that. COX-1 is inhibited by aspirin, but not COX-2. Remember, aspirin, I said in the last question, aspirin inhibits both COX-1 and COX-2. It's not selective. But the only thing about aspirin is that it irreversibly blocks it. COX-2 is inhibited by ibuprofen, but not COX. Again, ibuprofen is an NSAID, like it's not selective at all. Do you know the only selective COX-2 inhibitor? Like, what would I put here to make this right? Do you know the drug? So only inhibits COX-2 without good. So celecoxib is the only selective COX-2 inhibitor. Okay, the rest are non-selective, like ibuprofen, aspirin. So these two don't apply. So the correct answer is D. You're right. COX-1 is constitutive, while COX-2 is largely inducible. I know it's like it's playing around with the words, but constitutive means that it's always active. Largely inducible for COX-2 means that it's only induced or only produced in cases of like inflammation and so on, because you need more prostaglandins, right? So this is a picture. So you see how it's the same pathway, COX-1, COX-2, same pathway, but like the enzymes are used in the same pathway. Non-selective is NSAID. The only selective NSAID is COXib, which is celecoxib, inhibits COX-2, right? But generally the others are non-selective. They inhibit prostaglandin. COX-1 is always active because it protects gastric mucosa from ulcers, so it keeps like a healthy lining. Hemostasis because of platelets, renal function because of kidneys, okay? Kidney epithelium and so on. The only way COX-2 is active in our bodies is when we have pain, inflammation, like all those, infection. So in cases when it's abnormal, okay? So you have to add more when something wrong is, like something is wrong with your body, okay? Is that clear for everyone? Why it was D? Okay, good. Now we'll move on. So this was like I tried to cover the most important things from this lecture. So which is this one, selectivity and the difference between them. Okay, even aspirin, what the important effect is. Okay, the following analgesic lacks anti-inflammatory action. It's also very a simple question. Good. So this is a very simple question, but it's also important to understand because paracetamol can be used for like fever. You usually use paracetamol, right? But it has an anti-inflammatory, it doesn't have an anti-inflammatory action. So all of these ibuprofen NSAIDs, they have anti-inflammatory, they're antipyretic, everything. Paracetamol is the only one that does not have an anti-inflammatory effect. And I don't think you took these two too, so it's fine. Just leave them out. Just know about paracetamol. Is this clear? Okay, we'll move on to chemotherapy if this is clear. Okay, is it like all this topic? We took C. Okay, yeah, if you took C, it's fine. I'm just trying to say that paracetamol is the only one that lacks anti-inflammatory. Diclofenac sodium, I think that's also NSAIDs, if I'm not wrong. You can correct me, it's fine. But I just yeah. Yeah, it is. Okay, good. So again, all NSAIDs have anti-inflammatory action. Do you have any other questions for this part of the lecture? Antipyretics, anti-inflammatory. Okay, good. So we'll move on to chemotherapy. I think this is our last topic, so we're almost done. So a scenario about a woman who will undergo chemotherapy before surgery. This is a scenario. What mode of chemotherapy is this? I just want you to know this because it's important you differentiate. Okay, so chemotherapy given before surgery is called. Okay, someone said D. Does anyone have other answers for this? D. Okay, so if D is your answer, why not B? Like, what's adjuvant chemotherapy? What's the difference? Good, after surgery. So just know the difference between those two. Neo is like new, so before surgery. Adjuvant is after. So I just wanted you to know the difference. Neoadjuvant chemotherapy is the answer before surgery. Wait, I thought I put a picture. Okay, but yeah, there's a picture that has like basically neoadjuvant chemotherapy is used for large tumors if you want to reduce the size before surgery. You can do adjuvant on the same patient too. That's fine, but after surgery. Okay. Do you want to answer this one? Yeah, go ahead. So, which of the following letters describes the term effective palliation? Again, I just want you to get the main important. Okay, someone said C. So you have start of treatment for cancer, let's say, with chemotherapy, and these are the treatments, C and C. Good, so I'll move on. C is the correct answer. So wait, let me see if I have a slide. Oh, okay, I didn't put, but okay, what's D? Which type of treatment is D? You can see from the graph itself, but like what is it called? Curative. Good. So D, you can see quality of life is 100% like increased, which means you're curing the cancer. C is the answer here, which is effective palliation, because again, palliation is just to make the comfort, like to make the patients live more comfortably, have a better quality of life. But palliation is not curation, like curative, which means that it doesn't cure, it just treats like their current symptoms to make them live a better life, right? So again, this is also from your lecture. I hope this is clear. Okay. So this question is about, I think, wait, let me see. Okay, yeah. So this question is about asking you about consolidation. Which of the following defines the consolidation process? So yeah, consolidation is another term that you have to know from the chemo. This is principles of chemotherapy. So that's why we're not going into the drugs yet. Okay, B. Do you guys have other answers? So it's again, it's a like a definition based question, but I wanted you to know the like what consolidation means if they ask you. So consolidation is B, repetition of dose in a patient who achieves complete remission. What that means is if I okay, I didn't put I'll show you a picture if I after my like after we finish. But basically, consolidation is when a person is cured, like they completed the chemotherapy sessions, the cancer is like treated or the tumor is treated, but you still give a chemotherapy to make sure there's nothing left of that tumor or cancer. That's why it says repetition of the dose again, who has achieved already complete remission, which means they are cured. Or like the tumor is cured. So again, this one on the long term to prevent recurrence. So this is exactly like the wording in your slides. To prevent recurrence, no, because the main reason you're doing this is because you want to remove any residual tumor or cancer. That's why. Okay. Again, they're already complete remission. Improve quality of life, yes, but like not really, like it does in a way, but this is why it does. Like it achieves complete remission first. Okay, wait, Shamiaa, do you want, this is your part for chemotherapy.
Yeah, okay, so alhamdulillah guys, we reached the final part. So the first question, a 65-year-old female complained of numbness and hypersensitivity to the cold. Supposed to have like in her feet and extremities after receiving chemotherapy. What drug has most likely caused this reaction? D. Are there other answers? D again. No. Okay. Okay. So yeah. Okay. So the answer is D. Wait, can you? Yes. Okay, so because this is peripheral neuropathy, it's a side effect of vincristine, and we're going to see the side effects of the other drugs, and then we're going to come back and see the answers. Okay. So can we move on? Okay. So basically, chemotherapeutic agents, you have to know like 8 or something. So inshallah, it's gonna be very easy. So the first class is alkylating agents. From the name alkylating agents, it's gonna form a cross-link in the DNA, usually in the guanine nucleotide, guanine base. It's gonna form a cross-link, and therefore the DNA is not it's not gonna be able to do anything, and the cell is gonna die. Okay. And basically, cancer chemotherapy is divided into which phase does this cell act on. If it acts on the mitotic phase, or it's not specific, or S phase, which is the synthetic, or G1, which is just the growing phase, or G2, which is the proofreading phase. So for cyclophosphamide, it's phase non-specific. In the slides, it's phase non-specific. Maybe outside you'll find that it's G1, but like listen to what the slides say. And therefore it's phase non-specific, forming crosslinks between the DNA. But if there's one thing they're gonna ask you about cyclophosphamide, is its side effect. It causes something called hemorrhagic cystitis, okay? And how does it cause hemorrhagic cystitis? It's by something called there's a metabolite of cyclophosphamide called acrolein. The active metabolite of cyclophosphamide is something mustard. It has the word mustard in it, so just remember that. However, the one that causes the adverse effect is acrolein, or whatever it is. It causes hemorrhagic cystitis. And for you to prevent this, you need to give enough fluids and mesna, okay? So mesna is the drug that's given to prevent hemorrhagic cystitis that's caused by cyclophosphamide, which is a phase non-specific drug that alkylates the DNA and causes cross-linking. Okay, then we have antimetabolites. Antimetabolites are gonna inhibit the formation of basically purine synthesis or pyrimidine synthesis, and basically that's needed for the synthesis of DNA. And if you're not gonna be able to synthesize DNA, then this is gonna work in the S phase. Okay, so the drug that's specific in this category is methotrexate, and methotrexate inhibits an enzyme called dihydrofolate reductase. Yeah, that's the name of the enzyme. So it inhibits that, and you can remember it as methotrexate for dihydrofolate reductase. If you guys remember, which antibiotic worked the same way by inhibiting dihydrofolate reductase? Yeah, trimethoprim. No, not sulfonamide.
Trimethoprim.
Sulfonamide works a step before that in the formation of folic acid. It's dihydropteroate something. But yeah, that one. But not dihydrofolate reductase. Okay. So basically, side effect of it is myelosuppression. If you realize that all chemotherapeutic agents, their side effect is myelosuppression. But why is it important to know it? Yeah, you shouldn't memorize it for the others, but for methotrexate, it's important because you can actually prevent it by giving something called leucovorin. Leucovorin is basically folinic acid, and it's kind of bypasses the step of dihydrofolate. So if you give this, wouldn't the cancer cells also uptake it, and then there would be no effect of methotrexate? Or why do we give it? Or how does it work, Yani? If basically this drug bypasses this methotrexate and gives you the action, so wouldn't that also affect the cancer cells, and then methotrexate wouldn't work? Well, what's Yani? How is it? Yeah, folinic acid. No, but basically, regular cell. Yeah, but then basically methotrexate is still gonna affect the other cells and cause myelosuppression. When you give leucovorin, which is folinic acid, that can bypass this methotrexate step, it actually has, basically the normal cells uptake it much more than cancer cells. So cancer cells don't use that much as the normal cells, and that's why it's not going to affect our cancer therapy. So methotrexate will still be able to kill the cancer cells because the cancer cells are not uptaking as much leucovorin as the normal cells that we have, like the bone marrow cells. Okay, is that clear? Yeah, okay. Then we have vincalcaloids. So vincalcaloids and taxanes, both of them, they work on the mitotic phase. Mitotic phase, M phase, so they work on the microtubules, MM, okay? But the difference is that vincalcaloids are going to inhibit the polymerization, and taxanes are going to inhibit the depolarization. So for example, you need polymerization during the metaphase because you want to do the spindles and connect the sister chromatids and so on. Okay, but if you're not able to polymerize, you're not going to be able to do this M phase or mitosis and metaphase. And therefore, the cell's not going to divide, it's going to die, it's not going to be able to pass through. Okay, and taxanes, it's the opposite, where you're going to have depolymerization, inhibit the depolymerization. So basically, after you've already formed the spindles and so on, and now in anaphase, you have to separate. And how do you separate? By breaking down the microtubules or the spindles, but you're not able to because taxane is going to inhibit it. Okay, so how do we kind of remember this? I don't know if it's going to help you, but vincristine, kind of like is like crystal, and crystals are very fragile. You cannot really polymerize them. Okay, so in vincristine, you're not able to polymerize. However, paclitaxel kind of sounds like textile, and fabric is very hard to rip apart. So you're not able to depolymerize the taxels, but you're able to, and you're not able to polymerize the cristines. Okay, so vincristine inhibits polymerization, paclitaxel inhibits depolymerization, and they both work on the M phase because M microtubules. And very important side effects of vincalcaloids is the peripheral neuropathy, which is the one that I mentioned previously. This numbness, tingling, sensitivity to the cold or feeling cold. That is basically one of this peripheral neuropathy, which is for vincristine or vincalcaloids. Okay. Now for the other slide. Yeah, okay.
This one?
So a 75-year-old male presented to the ER with red urine. It was found that he was received a chemotherapeutic agent just recently. Which drug, if given, would have prevented this? C. Any other answers? C. Okay. Yes, leucovorin would prevent, or is given for what? Methotrexate, perfect. And acrolein is the metabolite causing all this problem, and the active metabolite of cyclophosphamide is something mustard. I don't know what it is, but it's mustard. Okay. So yeah. The next slide.
Yeah, we got this question in our exam, so
Yeah,
that's nice.
Phosphoramide mustard. Okay, thank you so much. Yeah. Okay.
Okay.
So yeah. Now we have the last 5 classes. First one is antibiotics. So antibiotics, because it was driven from some streptomyces species anyhow. So doxorubicin is the drug, doxorubicin. And doxorubicin causes basically intercalation between the DNA, which is usually not phase specific because the DNA is always there and you can intercalate it. However, it affects more of the S phase, because then what happens is that when topoisomerase, which prevents the supercoiling of DNA, wants to come and act, it's not going to be able to because there's intercalation. Okay, so doxorubicin is non-specific, but most of its actions is in S phase. Okay, very important side effect of doxorubicin is cardiotoxicity and cardiomyopathy. So you have to be very careful when giving doxorubicin and monitor the heart. Okay, so until now we took 4 important side effects: cyclophosphamide, hemorrhagic cystitis, zinc alkaloids, peripheral neuropathy. Methotrexate is the myelosuppression, and you give leucovorin. And now doxorubicin, it's cardiomyopathy. Okay, very important. Then we have etoposide, topoisomerase. So it's gonna inhibit topoisomerase 2. Okay, it inhibits topoisomerase 2. And that is why it's specific in the DNA synthesis stage and in the proofreading stage. So S phase and early G2 phase, and it's the only one that's really kind of G2. So yeah. Then we have the hormonal, which is, for example, tamoxifen. There's many, but an example is tamoxifen, which is anti-estrogen. So it's going to be used in cases where estrogen is the one that's growing the cancer. So for example, estrogen receptor positive breast cancer, right? So in that case, you can use tamoxifen. However, since you're antagonizing estrogen's effect, you're going to get symptoms that are similar to menopause. Because menopause, what happens? You have low estrogen. So it's the same thing. So you get hot flushes, amenorrhea, and so on because of this blockage of estrogen, similar to menopause. The last two, first we have antibodies like bevacizumab, which is basically a monoclonal antibody. MAB is monoclonal antibody, okay? And it inhibits the VEGF, which is the endothelial growth factor. And why is that important for cancer cells? Basically, cancer cells are going to release a lot of VEGF to cause neoangiogenesis and to produce increased blood vessels to receive blood and basically grow. So if you inhibit VEGF, then you're going to inhibit this neoangiogenesis process, and basically the cancer cells are not going to get enough blood and they're going to die, okay? So kind of to remember it, instead of bevacizumab, beveg, because veg, VEGF, okay? Bevacizumab. Again, it's phase non-specific because it doesn't depend on the cancer. It depends on the neoangiogenesis vessels, okay? Tamoxifen is also phase non-specific. Then we have the small molecules which end with NIB. All of them end with NIB, okay? But specifically this one, tinib, T for tyrosine kinase. So imatinib inhibits tyrosine kinase, okay? So it's a tyrosine kinase inhibitor. Why is this important? Specifically, imatinib in a specific cancer, which is the chronic myeloid leukemia, CML, what happens is there's translocation. The problem is the translocation, Philadelphia translocation, which is 922. And you form something called BCR, ABL tyrosine kinase receptor. So imatinib is going to inhibit this. And this is basically gonna inhibit the growth of the cell, and it's a miracle drug for CML. So CML, you use imatinib because tinib, tyrosine kinase inhibitor, specifically in G1 phase because growth of the cell. And yeah, it's used for CML. Okay, so I can move on. Okay. So a 54-year-old male was recently diagnosed with CML. It was discovered that his cells showed a 922 translocation. Which of the following drugs would be the most suitable treatment? D, tyrosine. What's the name of the drug? Imatinib. Which drug is topoisomerase 2 inhibitor? Toposide. Which one inhibits macrotubule depolarization? Paclitaxel. Good. And which one inhibits the polymerization? Vincristine. Okay. Which one is the DNA intercalator or intercalates DNA, which will ultimately also affect the topoisomerase because it won't be able to do its job? Doxorubicin and anti-estrogen. Tamoxifen. Okay, perfect. Okay. I'm gonna move on to the next slide. I think this is the last thing. So basically we said that they act in different phases. So remember, the drugs that act on the M phase are the ones that are gonna have to do something with microtubules, so vincristine or paclitaxel. On G1 phase, it's the growth phase, so tyrosine kinase inhibitor, which is imatinib. On G2 phase, early G2 phase is etoposide, okay? And then on the S phase, we have the antimetabolites or anything to do with topoisomerase. So etoposide and doxorubicin, although it intercalates, eventually it's going to basically kind of not allow the topoisomerase to do its job. And then phase non-specific, we have cyclophosphamide, because it doesn't matter. Tamoxifen, again, it doesn't matter. And bevacizumab, okay? So yeah, I think we have one more question and that's it. Should it be? Yeah. Okay. Which of the following drugs works on the early G2 phase? Etoposide, doxorubicin works on which phase? All but S specifically. Okay. Non-phase specific, but most active in S. Etoposide also works on S phase and early G2. Cyclophosphamide. Non-specific. Paclitaxel. M, and vincristine is also M. Tamoxifen is hormonal, non-specific. Okay, perfect. So yeah, the answer is etoposide. And this brings us
I think
to
we, yeah,
the end of our session.
wait,
Yeah.
let me see.
The image that you want to
Oh.
put here.
Oh my God. No, I think I added like just now on my phone,
Okay.
but this is a very like nice way to know. I don't know if like Shamiaa you use this, but I use this to memorize the side effects. So for example, okay, wait, not this one. For example, vincristine, do you see the V? So like V for arms and legs. That's peripheral neuro. These are side effects. So I'll put a title: side effects of chemotherapy. Vincristine for peripheral neuropathy, the limbs. I think this is still too early. Doxorubicin, the heart here. And then no problem. And then what else? Okay, so the things you didn't take yet, don't worry about them. Just do the ones you like took. For example, there's cyclophosphamide, which is a good one. Hemorrhagic cystitis, it's here. These C are something for something else. Cystoplatin, ototoxicity, nephrotoxicity. So it's fine, don't worry about them. And non-specific is for every chemotherapy. So hair loss, GI toxicity, so on. Okay, you can use this to memorize. But then, yeah, Shamiaa, I'm
It's
sorry
so
for
nice.
cutting you off, but we're done.
So nice. Yeah, thank you guys. We know it's such a long class session. We didn't think it gonna be this long. So I hope you guys benefited. If you guys have any questions, please let us know. And if you guys can please fill the feedback form, it's in the QR code. And yeah, you have our phone numbers and emails. You can email or text preferably. And yeah, good luck in your
Thank you guys for attending.
Yeah, thank you guys so much. Good luck.
Good luck.
Awesome, mashallah. I think you guys already know.